can present, because I will just show a couple of cases. I don't want to take time because I want you all to get appropriate cases which are presented. I think we should, it's time to go online because.
Yeah, we are live.
Karne sir is here.
Yeah, so we are live.
Just wait for a minute.
How many people are connected?
Yeah.
So it's live now.
Hello, sir.
Good evening, sir.
Hello, sir.
Is he able to hear?
Hello.
Good evening, sir. Are you able to hear us?
Oh, yeah. Good afternoon.
Yeah. Are we online, Ashok?
Just a minute. I'll show the disclaimer slide first and then hand it over.
Yeah. No problem.
Yeah. Ajay sir is
So,
online.
Hi.
Share screen karo ya.
So good evening, everybody, and welcome to the Spine Connect webinar. Let me get you through this disclaimer slide. Wait a minute. So we thank all our faculty for sharing their knowledge in these challenging times. We wish all our audience a healthy and safe day ahead. And as you know, these webinars depend on internet speed and a lot of technology, which can be unstable at times. So please bear with us if there are any issues with internet. So over to you, Shailesh sir.
Yeah. Good afternoon, everyone. This is the Pune Orthopedic Society and Pune Association of Spine Surgeons second webinar series called as Spine Connect. And we are briefing about the important orthopedic spine and neurospine issues which we are dealing in routine practice. Today's webinar is all about the lesions in spine. You know, a lot of time we get confusion. Sometimes we get patients with back pain. Recently, I had a patient with back pain, and he was at Ola, a taxi driver. He was being treated with medications, physio rehab, but was not getting better. And when it was investigated after 6 months, it came out to be a tumor. So these are the surprises which are all we all face. Therefore, we thought of getting this lesion in spine, mainly with TB or non-tuberculous lesions, metastasis, myelomas, lymphomas, and primary tumors. So this is the theme, and we have very eminent speakers today. We have Dr. Arun Ranganathan. He is a professor and lead in England. He is practicing at London, and he is one of the most eminent international masters today we have. Arun is awarded with many Volvo awards as well as Easels awards in spine surgery, and he is doing phenomenal work in deformity, complex spine, and advanced spine. Again, Dr. Ranganathan is one of the noted personalities in England, and recently he was on Channel 5 for worldwide live scoliosis surgery, which was telecasted all over the world. And it's a big credit that British Spine Society president was moderating the session and Arun was performing the surgery, and it went flawless. I saw the complete recording of that, and it was a great thing. Arun, I must compliment that a person from Indian origin is doing great work in London and all over the world. He's doing especially a lot of social cause. Also, he goes to different small countries where he is giving his spine surgery practice services. We welcome you, Arun, that you are a part of our Spine Connect, and thank you very much for being there.
Thank you so much.
Thank you. Our next faculty is one of the most eminent neurospine surgeon, Dr. Sushil Patkar, who is practicing in Pune. He's practicing at Pune Hospital and a few other hospitals in the city, as well as he goes as an invited surgeon for some distant places as well, wherever there is a complex case. He's famous for getting complexities under one roof, and his special work in spine is mainly on C1, C2, where we have seen his anterior approach to C1, C2. He is a phenomenal surgeon and very well respected in all the neuro as well as spine surgeons all over the country. And we are very happy to be there with you, Patkar sir, that you are giving us your time for this Spine Connect webinar of Pune Orthopedic Society and Pune Association of Spine Surgeons. Thank you for joining.
Thank you, Shailesh. Thank you.
we have Dr. Bibu Mohapatra, who is one of the most eminent personality, again from Indian Spine Injury Center, trained in Australia, trained in India, and now practicing for many years in Indian Spine Injury Center as unit head. And he's doing a great work. They are doing a lot of minimally invasive surgeries, robotic surgeries, and Dr. Mohapatra is known for his minimal access work all over the country. And we really welcome Dr. Mohapatra for being there. And he's a great person. He's a team member, as we all know. And Indian Spine Injury Center has a very big team where these guys are doing a phenomenal work. We welcome you, Dr. Mohapatra. Thank you for joining us.
Thank you, Shailesh. And thank you.
Thank you. Thank you.
Good evening, all.
Good evening. Our next faculty is Dr. Rajesh Parasnis. Dr. Parasnis is practicing in Pune, and he is practicing at Oyster and Pearl Hospital and 3-4 more centers where he is doing phenomenal work again. And he's one of the pioneer surgeon in Pune region for spine and difficult complexities. He's known for his work in lesions and tumors, where we will see his work today. And Rajesh has been a very good friend and a person, as he's a very good photographer. We see his lot of good work in photography as well. Thank you for joining us, Rajesh.
Thanks a lot, Satish.
Thank you. Our next speaker is Dr. Ajay Kothari. He is again a very budding and dynamic spine surgeon which we have. He's practicing at Sancheti Hospital, and he has a big gamut of surgeries from surgical complexities, deformities, tumors. Dr. Kothari is doing phenomenal work, and his work on minimal access surgery is getting good accolades all over. And we really have great support, as he's my colleague at Sancheti Hospital. We really thank you, Ajay, for joining us for this webinar in spinal.
Thank you so much.
And we have our next faculty, Dr. Himanshu Kulkarni. Dr. Himanshu is practicing at Shraddha Spine Hub in Sangli as well as Kolhapur region. It's a very big sugar belt of Maharashtra, and they are connected to 2 states at the same time, where he is getting a lot of work from this region. And we welcome you, Himanshu. Himanshu is doing phenomenally good work. Again, he's one of the most eminent person practicing in Sangli and Kolhapur belt. Thank you, Himanshu, for joining us.
Thank you very much, sir.
And last but not the least, Dr. Narayan Karne, who is one of the most senior most guys we all have, and he's the president of Pune Orthopedic Society. Without his help, this webinar was not possible, and he's given us 100% contribution to go ahead for spine webinar series for this month in association with Pune Association of Spine Surgeons. I would like Dr. Karne sir to say a few words, please.
Well, thank you, Dr. Shailesh. It's a great pleasure for the Pune Orthopedic Society to get associated with this wonderful webinar, which is extremely useful for not only the spine surgeons, but for the general orthopedic surgeons at large. Well, when Dr. Hargavkar told me about this, I was very much excited. This is a very important topic in day-to-day practice. When we get some lesion in the spine, orthopedic surgeons can just reach up to maximum to diagnosing that spine lesion, and then he can refer that to the spine surgeons. But then the diagnosis is very important, and the diagnosis extends right from the benign osteoporotic, senile osteoporotic lesion to the malignant or the metastasis one, which forces us to, which tells us, which we have to tell the patient that his days are numbered. So to differentiate that, to decide, to identify the spinal lesion and think about their management, this seminar has been organized. So I thank Pune Association of Spine Surgeons that they have associated with us for this. I welcome Dr. Arun Ranganathan, that he joined us all the way from London. Welcome.
Thank you so much.
I welcome my very good friend, Dr. Sushil Patkar, who is a really super surgeon and extremely knowledgeable person. I welcome Dr. Bivendu also from Delhi, and all other members.
Thank you, sir.
Kothari, Dr. Himanshu from our Pune Orthopedic Society. And I thank Dr. Ashok Sham also consistently to help all of us. And he has not allowed us to feel the loneliness of the lockdown for almost 2 months. I thank him also for that great quality and cooperation. All the best for this webinar. Thank you all, Dr. Shailesh.
Thank you, sir. Thank you for your kind words and a great support as always. I would like Dr. Rajesh Parasnis to say a few words from Pune Association of Spine Surgeons team.
Thanks, Shailesh. Pune Association of Spine Surgeons is an active group of spine surgeons which are working in the Pune region. We have more than 40 members so far. Most of us are ortho spine surgeons, but we also have eminent members like Dr. Patkar who are neurospine surgeons. We meet quite often to exchange ideas and to have a collective consensus about the kind of treatments for many spine ailments in Pune. And we have also successfully undertaken conferences like the ASICON in 2015 and subsequently the regional conferences also. So I'm very thankful to Shailesh to take this endeavor and take this initiative to bring the best of the faculty and exchange the ideas and the relatively difficult topic in the subspecialties of spine surgery. Over to you, Shailesh.
Thank you, Dr. Parasnis, for your kind words from Pune Association of Spine Surgeons. And I would like to thank Dr. Ashok Sham, Dr. Neeraj from Ortho TV for a great support, as always, for this webinar. And I would like to thank even Off-Treat for support for this webinar for us. I would like to again extend my thanks to Dr. Pradyuman Rathi, who is there as a coordinator for any questions. You can, we have the number of Dr. Rathi on all the WhatsApp groups, and for this webinar, you can definitely ask any question if you feel. Over to you, Ajay. I would like Ajay to start with his case, and this is mainly a case-based scenario with some amount of additional information. As this is a knowledge sharing platform, we would like Ajay to start the first case and the ideas about tumor, basically.
Yeah, sure. You share. Can everybody see?
Yes.
Yes.
Make it full screen. Can you make that full screen? Yeah, thank you.
Good evening, everyone. So without wasting much of time, we would start with the cases. So let's start with the first case. I'll be presenting two cases, and in this, I'll run you through to the newer classification systems which are followed in modern tumor surgeries, and the clinical relevance as to when to treat the patient surgically, when to treat the patient palliatively. I think we'll run through all those things in the process. So this is a 72-year-old male complaining of upper back pain, interscapular pain to be more specific, loss of weight, loss of appetite, no fever. He walks with support. He is around neuric grade 3 and power is around grade 3 plus in both lower limbs. So we got his imaging done. So we'd like to start with Dr. Patkar. Yes, your views on the MRI, Dr. Sushil Patkar.
Yeah, obviously, you see the lesion is in the posterior half of the vertebra plus the posterior elements, and there is soft tissue component to whatever I am seeing in the paraspinal images. Of course, no spinal tumor you should comment about till you see the CT scan. Without seeing the CT scan, it is wrong to comment about the extent of bony involvement. But definitely, you can see the lesion is predominantly involving the posterior half of the vertebra.
Correct.
Now, if you want to use, you look at this tumor is now, from what I can see on the screen, it is contained in the vertebral body. Is it come out? I can't see. You are showing the axial sections. Show me the axial sections.
Yes.
Yes, there is some tumor in the epidural space also. And there's tumor extending in the pedicle and the posterior elements and the head of the rib, if I am not mistaken.
Okay.
So now this would be somewhere in Tomita grade 4 or 5.
Okay.
And what investigations have you done to find out the primary, whether you got a bone scan on the patient?
This is your CT scan. You asked for a CT scan.
Yes, the CT scan shows an expansile bony lesion involving the transverse process, plus the lamina also is expanded, and there's osteolysis inside. So you can see this. To me, this would I would think of a giant cell tumor, because you're seeing this. There's a kind of cavitation in the posterior half of the vertebral body. Plus, you're seeing this soft tissue element over here, and the expanded transverse process over here.
Dr. Bibu, in India, they say that tuberculosis is very common and it can present in any atypical way. So, would you put one of the differential diagnosis as infection, like Dr. Patkar said, he feels it's a tumor and he's very confident about it. So Dr. Bibu, would you feel that this can come out to be an infection?
It may. Tuberculosis can present as a central type of tuberculosis, which can involve the bone. But if I look at if you may go back to the MRI, so if I look at the disc space are quite intact here.
Correct.
So if the disc space are intact, it goes more in favor of a tumor rather than an infection, spondylodiscitis. So I would keep the tumor as my first secondaries or a primary tumor as my first differential diagnosis, infection as second.
So my question to Dr. Arun is now, would you like to image this further? Like we did his blood workup, the myeloma profile, which is negative. So would you like to image him further in the form of nuclear tests like bone scan or a PET scan? Or would you like to go ahead, get a biopsy done? Or would you like to go ahead, get a surgical decompression done in view of his neurodeficit status? What would you do, Dr. Arun, in your practice?
We would normally get all the blood tests done.
Yeah, that is within normal limits.
Including ESR and
Yes.
white cell count and everything else.
Yes.
So if you're going more in favor of a tumor, we would definitely get a CT chest abdo-pelvis, and we would also get a PET scan.
Yeah.
Can I ask a question?
Yeah, sure.
If you're going to get a bone scan done, does the CT chest abdomen hold any relevance?
No,
if you're going to do a PET CT.
Yeah, so answering that question, Dr. Patkar, if one has an access to PET scan, I think in order to screen the bony skeleton as well as the soft tissues, PET scan would stand much higher. So that's comes as saying. Investigation of choice. But if in a smaller place, a district place where facility of PET scan is not available, then in those situations, I think doing a CT scan of chest and abdomen and then doing a skeletal survey would make more sense in absence of a PET scan. So this is what the PET scan report shows. So there is multiple skeletal involvement and there is also a lesion in the left lower lobe of lung. So this is his PET scan. So now, yes, Dr. Shailesh, over to you.
No, I think what you said is right. Most ideal is PET scan, and that is the first thing. But in case if it is not available, then CT abdo-pelvis and chest, we can do a brain also and do the remaining blood workup.
I would say that if a PET is not available, why not go ahead with a fine needle biopsy? That would give you the if your problem is you want to know the diagnosis, I would say a biopsy would be much quicker and faster.
The only thing is, Dr. Patkar, doing a CT chest abdo-pelvis would just tell you that if any easily accessible lesion is available for biopsy, then it would make more sense. That's the only advantage, and it will make you more wiser.
Which is on the surface in the transverse process, coming out in the transverse process and the lamina with hardly any bone over it. You think there's going to be difficulty in biopsying this?
This is not the, and I'm just talking in general. Means leave this case aside, but I'm talking in general. Like if it's tumor which is situated anteriorly, so doing the CT chest abdo-pelvis just give you an idea.
In relation to this lesion.
Okay.
By and large,
something, Ajay?
Yes, Dr. Parasnis, yeah.
See, by and large, non-invasive investigations, we always advise to do first. Second, the message here is obviously if it is accessible, you should do the biopsy, but it is not that in every case you will get an FNAC or fine needle aspiration cytology positive. Even with a true-cut biopsy, the success rate of positive lesion doesn't go to 100. So in the order of things, if you have an access, always better to do the non-invasive workup first and then you plan your biopsy properly.
Agree, totally agree. Yes, Dr. Arun, you had a point to make?
Yeah, so in UK, we normally manage this with a multidisciplinary approach. And these cases are usually presented to an oncologist. So we have radiologists, we have people from the chemotherapist. And if you have a neoplastic lesion, then a workup is almost mandatory.
Agree,
It
totally
can be
agree.
cut out a lot of the time. In case the patient is neurologically compromised or you are unable to access these investigations very quickly,
Correct.
and in favor of preserving neurology, then you can rush and do the final operation, but you still need to get the rest imaging done because you will always see something surprising.
So thank you, Dr. Arun. So we thought of doing a CT guided biopsy, and we did a biopsy in this particular case. I would like to ask the panelists that anybody would differ and anybody would like to go ahead with a definitive surgery in the form of stabilization, decompression, and getting the tissue for histopathology in order to tackle all the three things together. Dr. Paras, your views on that?
See, we already have a PET CT suggestive of a lung lesion.
Correct.
So there is a very high probability of this being a metastatic lesion.
Yes.
The minute you say that it's a malignancy which is beyond the primary, for the grading, staging, immunohistochemistry, to route a plan, and like Dr. Arun says, to have a multidisciplinary approach to have a tissue diagnosis is absolutely paramount. I would go further and say that a primary surgery, directly jumping, is a relatively contraindicated thing.
Okay. So we got CT guided biopsy in this case, and
one minute. Can you go back to that CT guided slide?
Yes.
Why did you not take the biopsy from here, and why did you choose this as the target? This was more on the surface. This was less dangerous. Why did you choose this as the target rather than this?
Sorry, I didn't get your question, Dr. Bhatkar.
Why did you not choose the transverse process, expanded transverse process as the target, which is far away from the spinal canal, rather than choosing this target?
Yeah, that's a very good question, Dr. Patkar. I think this is a CT guided biopsy, number one. So getting a tissue from a CT guided biopsy and getting the tissue from the transverse process is one of the options. But I think with the luxury of having three-dimensional imaging and getting a bigger size tissue, we thought of going ahead into the vertebral body, targeting the lesion and getting it done, because we had the luxury of getting a CT guided biopsy. So we thought
I know what you're saying, but why you think that you would not get a representative sample over here?
It can be done. It can be done. Getting a tissue from the transverse process also can be done, but we thought of going into the vertebral body so that we could get a bigger chunk size bony tissue in order to, have more chances of getting some positive result out of it.
Yes.
So, Ajay, can I add on something? Sushil, what Sushil sir is asking, so taking a biopsy through a needle, a fine needle, through a transverse process. Transverse is a very small bone. So going through and through, the possibility of getting a negative is higher rather than going through the whole bone and reaching the vertebral body. So you get the maximum chance of having the maximum tissue. So in case this biopsy is negative and you want to have a second go, so you can go in a small, open up a little bit and take that transfer process and come out. So that, I think that may be a little better way.
Yeah, I agree that any best possible, easiest lesion should be tapped. And most important is a good chunk of tissue should be, because sometimes it comes negative. Therefore, at least two sides we should try to take. So we can take it from where Dr. Kothari has taken, as well as we can take it from the
transfer process.
Yeah, transfer process. It makes it easier because we are definitely sure that we are going to get 95% chances that we'll get right diagnosis.
Yes, Dr.
Yeah,
Arun.
I agree. Yeah.
In view of neurology, do you start them on steroids before you've done the biopsy?
Yes, in this case, we had put her on steroids. We had. So the histopathology report, it turned out to be adenocarcinoma, and on doing the immunohistochemistry, the primary was from the lung.
Okay.
So now my question to the panelist is now, what would you like to do? Would you like to go ahead and plan a surgery, or would you like to do the scoring thing, or what? So yes, your views on this, Dr. Bibhu.
So I would see that if the patient, the neurology he was a paraparetic. No?
Paraparetic.
So Paraplegic. So I would definitely take a consult from my oncologist and get the staging and the idea what is the prognosis of this lesion.
Correct.
And would like to discuss that with the patient also. So whether, according to the score, I would see whether it has to be done as a palliative procedure or we can do as a definitive procedure. But seeing from the PET CT, there are other lesions also.
Yes.
So if it is a sensitive tumor, like if it's very chemosensitive or radiosensitive,
yes,
I would definitely give a radical surgical. I would like to go for a radical surgery at the point of lesion and take out as much as a lesion and tumor tissue and reconstruct it and then send it to the patient for further management by the oncologist.
So point well taken, Dr. Prabhu. I think for the benefit of the audience, what we usually follow is that we score these patients to know exactly how much mean survival this patient has, how much is his capacity to bear these major surgeries, and whether this surgery is going to have an impact on his overall outcome.
You can use the Tokuhashi score or the Tomato score.
So then, I'll just present 4 important scorings, not many, because there are hundreds of scorings available, but these are the 4 gold standard scorings.
Just brief it about,
So the first one, what we use is revised Tokuhashi score. So it goes on, first of all, general condition of the patient, number of extraspinal metastatic foci, number of metastasis in the vertebral bodies, metastasis to major internal organs and primary site of cancer, and spinal cord palsy. So in this case, this being a lung cancer with a spinal cord palsy, with metastasis to more than 3 vertebral bodies, it falls into a mean survival of less than 6 months in this patient. So the total scoring in this patient was 2, and total points is like less than 8. The mean survival is less than 6 months. 9 to 11, more than or equal to 6 months. And if it is around 12 to 15, then you look at more than 1 year of survival. So first is revised Tokuhashi score said that he would not make it more than 6 months. Then the next scoring system that we use is Tomita. Again, it is a very easy scoring system to use, and it looks into primary tumor, visceral metastasis, bony metastasis, and looking into this patient, it had a rapid growth, it had visceral mets, it had bony mets. So the total score was around 10, which again predicted the prognosis, that is survival, is less than 3 months in this particular patient. Third thing we look into is spine instability neoplastic scale, that's called SINS. So SINS is basically a classification system to know how much unstable the spine is and whether you would need any stabilization in association with the surgical decompression that you do. So that scoring also in this case was around 7, which said that it doesn't warrant any surgical fixation. And the last classification that we use in this tumor thing is a Bliski classification. So this Bliski classification is a classification basically for epidural spinal cord compression. So it is into 3 types, that is type O, type 1, type 2, and type 3. So type A is further subdivided into 1A, wherein there is just deformation of the thecal sac, 1B is impingement, and 1C is deformation of the thecal sac with abutment of the cord, but there is no cord compression. Grade 2 is cord compression, but CSF is still seen, and grade 3 is CSF is not seen with cord compression. So this basically falls into Bliski grade 2. So taking into all these classifications with a survivorship of less than 6 months, we thought of having a dialogue with the oncologist and with the patient and the family, and we thought of treating this patient non-surgically, and we handed it over to the oncologist for further chemo radio sessions. Your views on this, Dr. Shailesh or Dr. Rajesh?
No, Rajesh, so Ajay, what you did is a very, I can say a very right thing. You just check the classifications because it doesn't take much, getting the scoring, it will take half an hour for us to, it is not a very lengthy procedure. And at least we can prognosticate to this Tomita and Tokuhashi, they are the prognosticating scorings. and they give a generalized idea. But if we realize that these scorings were done very long back, 1990s, 2001, and then modified. Nowadays, because of the advanced chemotherapy and protocols, we are having a better outcomes even in adenocarcinomas. When we discuss with oncologists, they say, "Arey, I have a couple of cases which are doing more than five years survival. They are doing around." So this is one important thing, that these classifications are important. But
Genetic studies.
yeah, genetic study is now what the future is coming to, and a lot of people with no comorbidities, with neurological deficit, in pain, you can consider surgery. But when there is other comorbidities and the chances of life expectancy are very less, we can give them an option of non-surgical treatment as well, because ultimately longevity and survival is very, very important. Undergoing a major surgery, and again, the pain of surgery is also additionally there. But it's the most important thing is that have a dialogue with your oncologist, check what best treatment he can give, what is the latest from their side in this particular subtype of the tumor, genetic association, and the discussion with the family. Because again, the cost comes into this in case the patients are poor, and they have to arrange for a lot of money for this particular surgery. That also is a consideration. So it should be a multidisciplinary approach, discussion with the patient's family.
Dr. Parasnis, you had a point to make?
Yeah, if you allow me, you're already excellently espoused on all the relevant factors. I will just add a few comments if you permit me.
Yes, sir.
Whenever you're talking about a metastatic spinal lesion, not a primary, then I feel the three factors which are necessary to consider in the decision making. First of all is the tumor type. As you said that this was CL lung. Had it been some chemo or radio resistant tumor like OGX, primarily you need surgery for extirpation. The criteria is different. Vis-a-vis something like myeloma, that you know that surgery is not a primary choice. It responds excellently well for other modalities. This is one criteria. Second is the indication for surgery. What you described excellently was the prognostic criteria for surgeries. Indication for surgery still remain pathological fractures instability, progressive neurology, worse power than grade 3 bladder boil involvement, or persistent pain. Or in spite of giving chemoradiation and this, if patient comes with a debilitating pain, then you think surgery is necessary. And then when you are sure that surgery is necessary, then to decide the operability and the prognosis, modified Tokuhashi, Tomitan, all of this goes extreme lot. There also there is a differentiation between a primary tumor and a metastatic tumor.
Correct.
I think you've very well covered all the criteria that one needs to consider. But one finer point, let me add over here, that we also know that sometimes even metastasized adeno-CL lung, they can actually respond to biological agents.
Correct.
So that's why I say it's important. It's not just a chemo, and we are also talking about subtypes which respond very well. So suppose there is a scenario that you treat with that, longevity is better, patient has responded, but it comes with a pathological fracture, then probably will not hesitate to go in to make the patient in
Absolutely.
a better way to have quality of life.
Absolutely.
Thanks.
And just to sum up and give something newer advancement, there is something called as stereotactic radiosurgery. So this is like destruction of the precisely selected area of tissue using ionizing radiation rather than excision with a blade or doing a surgery. So basically we follow norms criteria. So it is like neurologic, oncologic, mechanical, and systemic. So based on these four things, one can decide whether to subject patient to EBRT, that is an open beam radiotherapy, or subject the patient to stereotactic radiosurgery. This is beyond the scope of this discussion. This is done by our oncoradiologist. But as a spine surgeon, as an orthopedic surgeon, we should know that this form of treatment does exist and it is coming up in a big way. And I think this is definitely going to be a very important tool as far as management of tumors are concerned. So yes, Dr. Arun.
So just a note on, CyberKnife for stereotactic radiosurgery. So normally, as a rule of thumb, these are ideal for cases where you have a dural margin. So if you don't have a dural margin, then it tends to be more of a surgical lesion. And I fully agree with all the classification systems, etc. But these are just guidelines. End of the day, in UK, if it's a fit and well patient and in terms of prolonging his quality of life, one of the important factors to consider is neurology. So you've started him on steroids. You've got a definitive diagnosis. You know that this is a tumor that is already spread and is more in the realms of chemotherapy. If he doesn't respond to steroids in 24 to 48 hours, purely to preserve neurology, of course, we know that neurology could be either due to, secondary to vascular spread, or it could be secondary to mechanical compression. So would anyone consider a simple decompression plus minus stabilization purely to give him a better chance? If this guy is going to live for a year, and if you can improve his neurology grade by 1 or 2 and keep him mobile, would anyone offer purely decompressive surgery, like palliative decompressive surgery?
I would say help him walk to the grave rather than be carried to the grave. Help him walk to the grave rather than be carried to the grave.
Yeah.
And now with minimal invasive fixation, I think even a unilateral fixation with a quick decompression at that site would work faster than doing radiation chemotherapy. My question to you guys is, how much importance in the UK you give to Karnofsky rating before offering surgery?
So we used to follow Tomita and SINS and a lot of other classifications, but basically now pretty much in most of the tumor centers, we don't really follow any classification or grading as such, because now the whole approach has become multidisciplinary. So in the same room, if you have an oncologist, so an oncologist is not familiar with Tomita or SINS or anything else. So all that he says is if this is responsive to chemotherapy or not. No. Usually they can give us a good prediction about the longevity. I mean, how many months he has to live.
My question is Karnofsky rating. My question is Karnofsky rating. That is, how good is his mental capacity? Is it very essential? Because many times in malignancy, you may not pick up lesions elsewhere, but still the patient is very slow in all their activities. That kind of patient invariably does not do well.
No, so that's why I said if he's a fit and well patient, then obviously we are looking at any form of surgical treatment. But if he's not, I mean, if this guy has atrial fibrillation, he's got previous stroke, he is elderly, he didn't have a good quality of life, then obviously surgery is out of the window.
Thank you, Dr. Arun. So if Dr. Shailesh permits, I'll quickly within 2
quickly
minutes,
I'll
run through. Yeah. There's a very important message in this case. So this was a case which happened some 3 months back, and a 52-year-old male, he came with chief complaints of bilateral lower limb weakness, and he also complained of grip weakness, which was progressive, history of loss of weight, loss of appetite, and symptoms are progressive. So upper and lower limb weakness. And this was his MRI. We got his MRI scan done. And I'll just run through all the images first. So basically, there was a lytic lesion in left half from S1 to S3, left sacral ella. So this is his MRI scan. And he had a lesion here in the left sacral ella from S1 to S3. And this gentleman had bilateral upper and lower limb weakness. So he had got bilateral grip weakness, biceps and triceps around grade 3+. And bilateral foot drop, and the neurology was progressively increasing. So this was his MRI report. So in view of his symptomatology, we got his PET scan also done to look for involvement in any other area. So this was his PET scan, which showed the only area where there was a lesion was around S1 to S3. So this was the PET scan report, which showed that there was a hypometabolic lesion from S1 to S3 vertebral levels, and it was extending into the spinal canal. But this, we need not really, put our brains together that why it would lead to weakness in both upper limbs and lower limbs. So this were his blood reports. And if you see here, he had a AS to G ratio reversal and his serum calcium was on the higher side. This was M band, which was positive. His immunoglobulin profile, IgA, IgG, IgM, was on the higher side. And we did a histopathology, which showed that it was a case of multiple myeloma. Now, one would answer that how his upper limb and lower limb weakness can be explained is through this, that multiple myeloma, there is a 5 to 7% prevalence of peripheral neuropathy at the stage of initial diagnosis. So one has to keep this at the back of the mind that any lesion with symptoms involving upper and lower limb and symptoms suggestive of peripheral neuropathy, I think one should always think of multiple myeloma. Yes, over to you, Dr. Shailesh.
Yeah, thank you, Ajay, for a wonderful presentation and briefing. That is what we needed. We welcome Dr. Appaji Krishnan, who has come. He joined. There was some technical error, therefore he joined 5-10 minutes later. Appaji Krishnan is one of the eminent spine surgeons in Chennai, and he was a big support system for the Association of Spine Surgeons of India, and he conducted the ASICON 2018 in a very big way. We welcome Appaji for giving us time today for the Spine Connect program, and we will start with Dr. Vibhu's presentation next. Yeah, Vibhu, you can share your screen, please. In the meantime, it is very important to understand the character of the patient, character of the tumor, also the presentation of the patient, because these are the two things which probably will change a lot of things. And over to you, Vibhu.
Okay, my screen is visible to everyone.
Yeah, you have to enlarge it. Yeah.
Okay, so I'm
Please
straight
make
away.
it full screen.
Yes, sir. Yes.
Play. Press play.
Is it okay now?
No. You go to full screen down.
Slideshow.
Sir, done.
Yes.
Okay. Got it, sir. So I'll be presenting a case of a lesion in the cervical spine with Castleman's disease. So this gentleman is a 51-year-old male presented to us with neck pain since our last 3 months, and he presented to us in January this year. So this gentleman had bilateral shoulder pain and radiating to the bilateral upper limbs since 1.5 months. His neurology was normal. There was no upper motor neuron signs, no constitutional symptoms. The neck pain increases in upright position, and range of movement was grossly restricted and painful. So he had come with this X-ray. So I'll just show you this X-ray. And this is the enlarged view of the X-ray, showing some expansile lesion in the posterior aspect of the C3 vertebral spinous process. So I would just a moment. So I would stop here for a moment and get discussion done. So how do we proceed from here? What are the differential diagnoses can come to our mind looking at this X-ray at a 51-year-old gentleman? Rajesh, your opinion, please.
Basically, any expansile lesion coming from the posterior elements, we think of neoplastic first. If it is only destructive, then again, as we discussed last case, TB needs to be ruled out. So this is not something you take lightly. You need to investigate further. You need better imaging. Both MRI and CT will be helpful. And there are predominantly tumors which arise from the posterior elements, and that too in this area. So we need to see the further imaging to decide whether we should go ahead with the biopsy.
Correct. So I will proceed further. I will go to the history of present illness. So the MRI, there was an MRI. The MRI was done in October, which showed enhancing expansor lesion in the vertebral body and posterior element of C3. And there were bilateral cervical node enlargements in the neck. Ultrasound of the neck was done, which showed multiple enlarged heterogeneous lymph nodes, more in the left than the right side. So the patient was advised for a lymph node. All these things were done before he reached us. So lymph node biopsy was done, which showed reactive lymphadenitis, and CT thorax and ultrasound of the abdomen was normal. Family history-wise, father was a case of non-Hodgkin's lymphoma, was treated in 2006 at TMX Mumbai. All the blood parameters were normal. Inflammatory markers were normal. So he was started on some antibiotics and ATT also. So lymph node enlargement persisted even after a course of antibiotics. And the histopathology from the lymph node showed features of Castleman's disease, which was a mixed variety. So this is the histopathology report, which is consistent with Castleman disease. And the patient went for a referral to another higher center in Calcutta, where the patient was advised observation and a spine surgeon opinion. Now, these are the CT pictures showing a large lytic lesion, expansion and lytic lesion with cortical breach in the C3 spinous process. Also, there is lysis in the anterior vertebral body of C3. The facet joints are also involved, and it's more involved on the left side, and there is cortical breach. Spinous process involved breach of the cortex. So these are the coronal images of the CT scan. So this is the MRI showing soft tissue
Extensive lymphadenopathy.
extension into the canal, more on the left side. T1, T2, STERM on SAG MRI. Axial MRIs. Huge amount of destruction of the spine, soft tissue encroachment in the canal, more on the left side. So this was the X-ray what we did in our center when we did a flexion under supervision, a flexion and extension X-ray. Now, let me start. How do we proceed from here? Apaji, you came late, so let's start from you. So how do you proceed? So we have given the X-ray, we have given MRI, I've given you CT. So what more information do you want here?
So the biopsy report also, yeah, the biopsy report also is available now.
So no, biopsy now.
Okay.
In this case, yeah. So if
So
you
I
want a
would like
biopsy, so whether you
Yeah,
want a
I will-
biopsy to be done?
Yes. And if there is two things. One is whether this is a single lesion, if we can get a bone scan or a PET CT to rule out other lesions. And with the lymph node biopsy, you said it's only lymphadenitis, so ruling out the secondary. I would like a primary biopsy from this lesion.
So how many of the panelists would like to go for only biopsy in this kind of picture with cortical breakdown, with soft tissue encroachment, only biopsy, or they would like to see a PET CT scan before a biopsy?
Yeah, let's ask Arun.
The dictum is always to get all forms of non-invasive imaging, especially if it's an atypical tumor, before you look at anything invasive. So we would normally investigate, so full blood workup, PET CT, CT chest, abdomen, pelvis. I mean, that is, we won't discuss a case without that.
So as already discussed by Ajay, so wherever the PET CT is available, we're definitely going for a PET CT rather than going a CT chest, abdomen, and brain. So I'm sorry, why it's not moving. So we did a PET CT scan, and the PET CT scan showed metabolically active bilateral cervical nodes and a metabolic active lytic expansor lesion in C3 and no other active lesions anywhere in the skeletal system. Now, coming back to, so Ajay,
Yeah.
so what would you now do? So whether we should go in for a biopsy only, I'm sorry, or you'd like to go in biopsy and stabilization at this moment?
I think I would definitely do a CT guided biopsy in this particular case. I would do a biopsy, get the diagnosis, because what would happen is, Bibu, if this tumor is a highly radio or chemosensitive tumor, then many of the times you can have a regression of the tumor just by the chemo or the radio thing itself. Then your surgery, you can save a surgical exercise. I'm not saying that in this particular case, but as far as possible, the dictum is we follow a biopsy first and wait for 3 days, let the report come, and then go ahead.
Okay.
Okay.
Sushil sir, your opinion in this case, in this particular case, what you say, Ajay, is quite correct. So we should try to get a biopsy as far as possible and see whether it's a chemosensitive or radiosensitive. And a lot of times, the patient does well without any additional intervention. But with this kind of picture, when there is cortical breakdown and severe expansor lesion, so do you think, suppose we presume that it's a radiosensitive tumor or a chemosensitive tumor, so still the patient, does the pain will reduce, that instability pain will come down with radiotherapy and chemotherapy only?
No, I totally agree. I'm not disagreeing. Means that would be the plan B. But at least once I know what the tumor is, what the prognosis is going to be like, I think we can have a better dialogue with the patient. We can have an oncologist on panel. So I think we are fully geared up before we take off the flight. That's the most important part.
Yeah, Rajesh.
See, Castleman's disease usually responds to immunotherapy. But are we assuming here that since he has a Castleman's or lymphadenitis, the vertebral lesions are the same? Whatever meager knowledge I have, Castleman's can have subtypes. It's the plasma cell variety which is higher preponderance of vertebral or marrow involvement. So we have two issues here. We have vertebral lesion. We have probably an unstable situation with mechanical pain with neurology intact. One of the options that I would consider is to put in a halo, external immobilization, till I get my biopsy and confirmation, and then go ahead by the oncoimmunotherapist what is to be done further. Suppose the response is going to be great, and in some of the cases you do see cortical regeneration or good osseous tissue developing post-immunotherapy, then I would just continue that. Otherwise, probably in conjunction with the oncoimmunotherapist, I will consider internal stabilization without entering the lesion very aggressively, because it's going to respond to the other treatments.
It will be just.
So, Rajesh, you think that suppose, and as the literature says, that Castleman disease can be associated with myeloma, what you say?
Yes.
So that's what you say.
Also, lymphoma also.
Lymphoma also.
Father had initially.
So, yeah. So suppose the pathology at C3 is different from what we see in a lymph node.
So what I omitted is biopsy is a must. Till that time, I will consider external immobilization, get a biopsy, then have histochemistry in conjunction with the tumor board or oncologist in picture, and then take a collective decision about surgery rather than going.
Shailesh, what is your opinion?
No, this is again a multidisciplinary and team approach. I feel. I think we need to understand all the markers, and I will prefer minimally invasive or non-invasive procedure rather than going ahead for any immediate surgical option. I will prefer a biopsy before I intervene.
So here,
yeah,
what we did is we discussed all the options with the patient. The patient is a very educated guy.
Correct.
So he had come well prepared.
Okay.
So we discussed all the options. There is one vis-a-vis only biopsy with some kind of external immobilization.
Okay.
And see how we go. And depending on the biopsy result, and then we proceed further.
Okay.
Whether we just do a chemo or a radio or a surgical plus chemo.
Okay.
So we gave them option, but the patient said that can this biopsy take away my pain?
Okay.
So the other option which we discussed with the patient, because we discussed our oncologist and the medical oncologist also that regarding the Castleman disease. And he also discussed the same thing what Ajay said, that this may be associated with lymphoma and myeloma, which are quite radiosensitive.
Yeah.
But it can be something else also.
Okay.
So we discussed these options. And we gave them option. The second option was to stabilize it and take a biopsy, wait for the histopathology report, and depending on that we go ahead with the further management. So the patient opted that if my pain can be taken off by a stabilization, so we'll go ahead with that. So we planned for a surgery in this patient.
Okay.
So if we plan for a surgery, so what would be your fixation or type of surgical approach, anterior or posterior, in this case?
Yes,
so,
Ajay.
Ajay, okay. Ajay.
Can I have a look at the
one minute, before Ajay answers that, I want to know what is the explanation for the pain?
Instability. As well as
instability, pathological instability, pathological fracture.
I didn't find a lot of instability on the X-rays. Did you find a lot of instability on the X-rays?
So the whole facet is destroyed. The lamina is destroyed, and
the flexion extension
anterior
X-rays
and the vertebral body, the severe loss of trabeculae.
All right, but on the flexion extension, did you notice any movement?
No, so but even if there is no movement in the flexion and extension, but the weight of the head can cause compressive stress on the vertebral body itself. Your movement can give stress rises at the weak point of the vertebra itself. So that can cause...
That bone will collapse. But if on flexion extension you're not seeing any movement, the vertebral height is maintained, how are you telling me that this is because of instability?
Yeah, Rajesh.
Difficult for me to digest that.
In cervical spine or even in lumbar spine or thoracolumbar instabilities, it is known, accepted in literature that dynamic views may not always show us instabilities. The reason for that is first of all, extensive muscle spasm due to pain. Second, there could be micro instabilities or macro instabilities. And third, remember that the facetal configuration here may not always show translation. It is just the wet bearing and the cortical erosions and the destruction close to the facets can cause instability pain. Sometimes the interosseous tissue, which may or may not be malignant, neoplastic tissue itself can be a cause of pain. But when
show me the axial images. Show me the axial images.
Yeah, these CT images, if you see, you will see a lot of cortical.
Axial of MRI or axial of
I feel this is responsible for the pain where there's compression at the level of the foramina. I feel it is basically root compression which is responsible for the pain in this case, and not instability.
The patient complained of bilateral radicular pain.
It's all right. It can be. You see the disease is quite extensive.
I'm sorry, sir.
Look at this disease on the left side. There's a lot of disease going in the foramen.
Dr. Bebu shows the CT, please. CT images you showed some time back. Yeah.
I'm sorry. I'll go back.
Yeah.
So this is the CT.
Yeah. Look at this.
Second image.
If you look at the second image, there is absolute gross destruction of the
Yeah. So
Yeah,
there
it
is
is.
some element of compression. There is no question in my mind. That's all right. Fine. So let's go ahead.
Maybe clinical scenario at times when we see at that it can be slightly
Correct,
different and experience.
Fine.
Yeah, Ajay,
Go ahead,
tell me.
So I think Dr. Bibu, the first thing is it's a posterior compression, so it would be a posterior surgery. Number
Yes.
one. So as far as the posterior surgery is concerned, my main challenge in this case would be getting a hold in an extremely osteoporotic bone. So I would first start with getting a C2 pedicle. I would start with even C4 pedicle if I can easily get through, if I have an access to OM or something, or lateral mass. And if I find that the hold is not satisfactory in C2 and C4, then I would not hesitate in going higher up as well. So maybe spanning 2 levels, 3 levels above and 2, 3 levels below. So I would also keep an option of occipito-cervical fusion with instrumentation in this particular case.
I
So
don't agree with you, Ajay. There is no logic in
yes, sir,
having the
Sushil, sir.
occiput into this fixation.
The Dr.
Sushil,
Patkar,
sir.
if you see the CT scan, the bones are extremely. I'm saying it's a
Right. Then do
fallback
the
option.
decompression, turn around, and do an anterior plating from C2 to C4,
I
and
think
put a bone graft at C3. What is the logic in taking the head on and fixing the head onto the spine when the problem is only at C3?
see, the problem is the osteoporotic bone. So what I'm saying is it's a fallback option. If I have a good hold in C2, C4, and if I, get a good access to that, definitely that would be the plan. But if it's an extremely osteoporotic bone where the hold is not that good, I would keep it as a backup
Then you
option.
think the occiput would be very good to fix?
No, at least it would have more anchors. So it would be a larger construct, which would make it comparatively more stable.
Yeah, it's a different. Both of you are.
Everybody can differ.
Yes, let's see what Bibu has.
Many ways to skin a cat.
Yeah.
Right, sir. So what Ajay says is correct. If you may have to extend your fusion, but there are if there is a bones are very weak, but there are other ways also when you can restrict your fixation and increase your stiffness and preserve your motion also.
Yes.
So
you can just go anterior plus posterior and save some levels.
Yeah, we can do that also.
You can go anterior single level colpectomy, C2 to C4 fusion, and posteriorly you can just fix 2 levels. So we will be saving a lot of mobile segments.
Okay. So so suppose what we had planned is to fix and take a biopsy first. And suppose it's a radiosensitive tumor, so we are stabilizing it, we are taking care of the pain, and then we can go in for a radiotherapy for the treatment of or radiochemotherapy.
Yeah.
So suppose the patient goes for a radiotherapy and we are fixing the spine, you're saying. So will the 2 rods will be good enough, or we need to augment it with more rods? Because nowadays the concept of multi-rod fixations is coming up. So would you prefer with only, suppose you're fixing only posterior, so will you be happy with 2 rods here with this kind of bone, or would you like to have a multi-rod fixation and then go in for a radiotherapy or a chemotherapy?
I think multi-rod has come more in lumbar spine where the stresses are much higher than the cervical spine. And basically it is for lumbar body tumors. Also, I don't know whether the same applies to the cervical spine.
I think it was, basically described for spinal osteotomies, wherein the stresses are very high. So before the fusion happens, one need to really augment it because they found a lot of implant breakage, the rod breakage at the osteotomy site. But I think can be done in this particular case.
Yeah, exactly. And the papers are for osteoporotic vertebral compression fractures at thoracolumbar junction also. So you can use double rods there because the forces are pretty much higher. So in cervical spine, you probably can let it go.
Interesting. Let's see what Bibu you have done.
Okay, we're running short of time. So what we did is,
just one thing before surgery.
Arun,
before surgery, would anyone consider a vertebral angiogram? A vertebral artery angiogram?
So this is a very good, valid point. So what we do is whenever we see an MRI, so we look for the flow voids here. And we definitely go in and discuss with a radiologist regarding this. If we have a doubt regarding, and there's a lot of flow voids in around the lesion, we definitely would consider a embolism prior to the surgery to reduce the vascularity. But in this case, we didn't find any flow void, significant flow void. So that's why we didn't consider any embolization.
Okay, yeah, let's see. Okay.
Sorry,
So Rajesh, you had a point to.
Yeah, till you load the next slide, I just want to put a comment. Here we are concerned about the bone anchors. So if at all the construct is going to be jeopardized, we will be worried about the screws coming out. That is not going to be held by adding rods to it. So probably having more levels on each side, or best would be to have an anterior support. So the cautionary measure over here, what is absolutely of paramount importance is once you have a biopsy, consider whether the tumor treatment is going to leave behind a lot of void, lot of instability anteriorly. Then you will have to do a secondary anterior construction. No amount of implantation posterior is going to help you. But if suppose post-therapy, post-immuno or chemotherapy, it is going to be good bone consolidation, you just support it more externally. But one more thing which will help you construct is addition of sublaminar titanium cables or wires or even interspinous cables. Because no amount of porosis is going to, your additional screws or whatever levels, if there is substantial porosis, is not going to be held. But sublaminar wires or cables will.
Yes, Arun.
So the reason for doing the vertebral artery angiogram is because if you look at the axials, you can't see the vertebral artery on one side. If I'm correct, I think it's the left side. So if you don't have flow through that particular vertebral artery, then you have to be very careful instrumenting the opposite side, because then you run the risk of causing a stroke. So if the patency of the vertebral artery is not there on one side, then you want to do all your instrumentation on one side and try to use anchors where you don't compromise, or you have a very low risk of compromising the vertebral artery circulation on that side. So if the vertebral artery is compromised on one side and you can't get anchors on that side because of osteoporosis or extensive bone destruction, then the option is to go for a long construct. And I fully agree that the occiput should be included. And the second thing is, if that is not possible, then you can go in more for the halo option. In fact, a trial of halo would be good before undertaking surgical intervention to see if the patient's pain goes away. If the patient's pain is not going away with a trial halo, then it's possible that his pain is more from venous congestion of the tumor or some other reason. I mean, that's purely my opinion.
Quite correct. Arun, quite correct. And Rajesh also point well taken. So Arun, any case wherever we try to fix and go in for C2 or above, we always do a MR angiography or a CT angiography of the neck. So we had done an MR angiography and we had found that both the vertebral arteries were patent here. Yeah. So what we did is, sorry, so I'm going back. So what we did is, we had a discussion and we asked with the patient. So we had C2 to C5, C6 construct, and we had an additional C2 laminar screw on one side, which we connected with a lateral mass, and the pedicle screw of C2 is connected with the pedicle screw of the C5 on the left side. And we sent the tissue and decompress the nerve and sent the tissue for biopsy, histopathology, and the biopsy, as said in the literature, came out to be a plasma cell neoplasm.
Well done, Bibu, and it's an excellent execution of the case. Points well taken from all of us, because these are the challenges, okay, whether we should go in front, what all things we should do, and as a policy, all the things we have to keep it in mind when we are dealing with such complicated and complex tumor. Excellent job. I must compliment for you and your team because there are different ways to skin a cat. No one is right or wrong in this. And ultimately, the outcome is very, very important.
Compliments, Dr. Vibhu, very innovative fixation levels. Just last word for our education. What was the prognosis? What was the outcome of this eventually?
So the patient is now undergoing radiotherapy.
Okay.
We waited for 4 weeks and then we started him on radiotherapy.
Okay.
And is right now in Nimans, Bangalore.
Okay.
So we'll be following him up with an X-ray and a CT to see what is the condition of the bone, and then we decide for a second stage or not.
Perfect.
Dr. Vibhu, what do you feel now? Just now you're relying only on that implant. Eventually, if the vertebra in the front collapses, is that implant is going to get stressed because there's no bone in your fixation anywhere.
So right now, sir, the thing is, if it's a plasma cell, neoplasm very sensitive, and the bones quality also gets better on radiotherapy and chemotherapy. So the patient is undergoing radiotherapy, and we have counseled the patient in case the patient has no pain. The pain is significantly less now. So, and we have counseled that we'll be reviewing his X-rays and CTs in case we see there is the destruction is not getting better, then we will go in for a second stage anterior surgery.
Okay. Well done.
Excellent case, Dr. Vibhu.
Yeah.
Thank you.
I would like Vibhu to go through your second case as a rapid fire, and then we go to Dr. Appaji for his presentation. Yes, Vibhu, you can just rapid fire your case, the next case.
Yeah.
Dobara mat puchna case. Just go ahead.
नहीं इसमें discussion नहीं करेंगे. I'll just go ahead.
Yeah, because we have. Appaji, you ready with your case?
Yeah, it's ready, Sailesh.
Yeah.
So this is a 35-year-old male patient who presented to us with severe low back pain and bilateral lower limb radiculopathy for 6 months duration. The pain had aggravated to a significant level for the last 15 days, and the patient had presented to us with bilateral progressive foot drop since last 1 month, and there is a fast history of the right tibial nail. So on examination, there was no local rise of temperature. The tenderness was present in paraspinal area with L4, 5, L5, S1 region. Bilateral SLR was 70 degrees, decreased sensation in L5, S1 dermatome bilaterally, no upper motor neuron signs. So on neurological examination, bilateral L4, L5 and S1 were weak, and I'm sorry, I'm not able to get the first MRI, which the patient had brought it with himself. I couldn't find in our hospital system, but the dynamic MRI showed instability at L4-5, significant instability. There's an angular instability at L4-5. So, and at L5-S1, there was a right-sided disc herniation also, right paracentral central disc herniation. And the L4-5, I'm telling you, but I had remember this, there was a significant large disc herniation with end plate modic changes and angular kyphosis. So what we decided is we did a L4-5 minimal invasive transforaminal lumbar interbody fusion and L5-S1 microdiscectomy. So the post-operative course was uneventful, and patient was mobilized with significant less pain and discharged on day 5. So this was the post-op X-ray. But patient was readmitted. I'm sorry, this is 3 days. The patient was readmitted after 3 days after the discharge with severe low back pain, and the pain was non-radiating. Severe intensity around 8 out of 10, aggravated on movement, including turning and bed, partially, and he was hardly able to stand up. He was standing on a very forward bent crooked position, and there was no further neurological deterioration. On examination, on the TLC count was 11,400. His CRP was highly raised, around 115, and ESR was 99. So this was the X-ray. We did a repeat X-ray. So this is not the right MRI. I'm sorry. So the MRI in the term sequence and we did a contrast enhanced. There was significant enhancement around the L5S1 end plates and this peridiscal area. So we did not go in for a disc tissue aspiration or a needle biopsy as the yield is very low as per the literature. So, and we went for a blood culture. The blood culture somehow showed a positive for Burkholderia cepacia, and which was sensitive to meropenem. Burkholderia is an organism, a gram-negative aerobic organism, bacilli, which is usually seen in immunocompromised patient and old age patients. But here the patient was young. He has no immunocompromised features. So we're a little worried. Why? So anyway, we started him on meropenem, 1 gram TDS with other analgesics, antipyretics. In the meantime, we removed the suture. He was in the hospital, and gradually his pain and fever settled down, and he could be mobilized to the toilet. Hematological parameters also improved with time, and patient was discharged with advice of IV antibiotics for 6 weeks. But 3 weeks later, again, the pain aggravated significantly, and he again came back on a stretcher and said that I'm not able to walk. So again, the parameters were seen. The ESR had come down. It was 63 and CRP was 30. In view of the recurrence of the symptoms, the patient was planned for a surgical debridement. Despite antibiotics, and the patient was not improved, so we planned for a debridement and extension of the stabilization. So we extended we did an MIS procedure, but during the procedure, because of the debridement, the right side L5 screw got exposed. So I removed the L5 screw. So I did a TLIF at L5S1, and so the patient was again mobilized, and the pain improved. The pain came down to VAS2, and meropenem was continued for a total of 6 weeks, and it was followed by Dalasin tablet, Dalasin for 6 weeks more. At present, the patient is quite comfortable walking and is gone back to his work. The only thing is why I wanted to present this case was because of the organism which was found, which is not very common. Only hardly 6 to 7 cases has been reported in literature, and it's usually seen in immunocompromised, as I said, immunocompromised patients and old patients. That's it.
Very well done. Vibhu, any faculty wants to say anything?
I want to know why you use the titanium cage. Is titanium cage better when there's infection?
So there's a lot of debate regarding this titanium and PEEK cages in the literature. Initially, it was thought that titanium is safer to be used in presence of infection. But the recent studies and literature and the systemic reviews have shown that there is no significant advantage of titanium over PEEK, and the fusion rates are equal in both the cages, although the sinking of the cages are slightly higher in titanium cages, in case of titanium cages, but which is statistically not significant. Yeah, Rajesh, you had a point.
First of all, excellent case to know, and so many new organisms coming up. We are just baffled. Dependent on the infectious disease specialist.
We are having a number of.
Yeah. But the other thing we do, let me just be the devil's advocate. When you maintain, and I would have done the same thing, be aggressive when your implants are there. The second time patient comes up, you can't just rely on the IV antibiotics. Debride, do everything, probably your screw was loose. So you had to go to S1. But is there any risk of going again in the lower disc when you're treating it with the disc above? You got my point. See, first you did an excellent TLIF and it got probably spondylodiscitis at 4-5. It is known sometimes when you debride lower down in the disc, when you take away the material and go to the subchondral bone, there is hypervascularity. So it is known sometimes that second level may get infected. This is the thing. And the literature may have shown almost no difference between PEEK and titanium, but if you discuss off the record with many surgeons, somehow we have a bias. If there is a slightest of risk, I would prefer a titanium cage. And one of the reasons is you can track what is happening to the end plates, where it's going and what's.
No, I totally agree with you. I totally agree with you. With the literature says that even if you just debride it, a good debridement, that will heal the lesion.
Yeah.
You just stabilize it and just debride it. So the most important is the debridement. Good debridement.
Yeah, we'll go to the next presenter, Dr. Apaji Krishnan. Would you please share your screen? You have to close your screen, Dr. Mohapatra.
Yeah. I'm closing. Closed.
Yeah. Okay.
Is the screen seen now?
Yeah, we can see that.
Yeah. Okay. So this is a different case, but most of the points have been already discussed. So I think it's just going to be a fast case presentation.
Yeah.
Ajay has actually told you all the principles of how to go about in a spinal tumor case. So step by step, the same thing. So this is a 19-year-old girl, mid backache, unrelenting with all exercises and water physiotherapy, 3 months time. Night pain, which was a red flag, but there was no appetite or weight loss. The pain was radiating to both the flanks, and neurological examination was not significant. She was neurologically intact. Sorry, I missed the pre-op X-ray. This is one of the intraoperative this thing. So the X-ray was very clear. It showed some lighted lesion in D11 with one of the pedicles showing the wing sign. Typically, I somehow misplaced that X-ray. I was trying to look at it. So it was a lighted lesion, D11. So the next thing which we do, this patient actually came with these 3 investigations from my friend. So he has already done an MRI for this patient. So that's the MRI. So so the same principles, I think, if anybody wants to take a call, can you think of a primary or a metastasis or a primary sarcomatous or a primary benign?
Yes, Himanshu.
It doesn't look benign to me, sir. The
Yeah.
pedicle, the pedicle is
CT scan.
involved. Yeah. So we might have to go for a CT scan. The transverse process is involved. Pedicle is involved. The looking at disease extension probably doesn't look benign to me.
Arun, what do you feel?
I'll show the next MRI picture also.
Yes, sir.
So you can see the right pedicle completely destroyed.
Yeah.
The left pedicle is intact. And then it's almost 5/6 of the body destroyed with a huge soft tissue mass. But if you can clearly see, it was contained within that exposed. There was a capsular like lesion. Yeah. Yeah, Arun.
Hello, Arun.
May I comment?
Arun,
Rajesh. Yeah, please.
Apaji, there are a few signs radiologically I just want others' attention to. One is infiltrative kind of infiltration.
Yes.
It's all throughout. It is slight tumor mass on the opposite side. And one very important thing is the involvement of the costovertebral junction on the side. So these are known to be in favor of malignancy, a malignant lesion. And this is happening in a 19-year-old patient, right?
Yeah.
So very remotely it is going to be metastatic. It's primary malignancy is something what we need to consider. It is not hyperintense on T2, or sometimes you have endothelioma, reticular endothelioma, hemangioendothelioma, something like a borderline aggressive benign plus malignancy kind of picture. But this
locally malignant primary
differential over here.
Locally aggressive
or malignant primary tumor. Maybe.
Can it be eosinophilic granuloma, EBC?
Eosinophilic granuloma doesn't look like a eosinophilic granuloma.
Doesn't look like vertebra plana. Yeah, vertebra
plana.
Neurofibromatosis.
Can be a GCT. 19-year-old can be a GCT.
Yeah, as rightly said, primary looks like more of a
bimodal presentation. Bimodal presentation can be in young and can be middle-aged person. So GCT will be my first differential diagnosis, if you say, looking at this picture.
What is her blood workup? I mean,
her blood workup is, now coming to two things. One is blood workup and PET CT. So this is the only lesion in PET CT. Blood workup is absolutely normal.
Normal.
Okay. I mean, obviously you guys see tuberculosis a lot more than me. Would this be tuberculosis given the degree of soft tissue involvement?
A central type without involvement of disc. That's what you want to say.
With preserved
But the
vertebral
elements
height.
are also involved.
With preserved vertebral height, with expansile lesion in the transverse process, I would not.
This is unlikely,
Very
unlikely to be tuberculosis.
Anything can be DV.
Unlikely. And the disc space are intact.
Bidu, did I discuss this case with you before?
No. I don't remember.
Okay.
My memory is very short. Don't worry.
Okay.
Okay. Yes.
So we did a PET CT. This was the only lesion. Blood parameters were normal. How many of you have a tumor board in your hospital? So we have a tumor board. So they insist on 4 basic things before you even. I mean, there's no primary surgery allowed at all. And as Arun said, we don't follow all those classification. We cannot discuss classification in them. We can discuss with ourselves. So we have a radiologist, pathologist, medical oncologist, surgical oncologist, plus me. So I go and present this case. So they said CT guided biopsy. CT guided biopsy said multinucleate giant cells. Okay, and then the tumor board, again we sat down, they said go ahead and operate, no need for any chemotherapy. So medical treatment was discussed. How many of you believe in denosumab in these patients? I mean, if there is a multinucleate giant cell.
It is known to have effect, especially cystic tumors in JCT. But the criteria, I don't think this tumor will respond so well with so much of intracanal extension and going into the cord, all that. And denosumab not necessarily takes away the need for the surgery. After denosumab,
yes.
You can adjunct.
Shrink it to some extent, and you might have to go and decompress as well.
So 2 points were discussed in the tumor board. See, I'm totally carpenter. Give me a case, I'll do just remove things, stabilize, and I don't even read about.
All of us here are carpenters. Don't worry.
So these 2 points which were told to me in the tumor board. One is if you give denosumab in an extremity GCT, it does shrink and it makes surgery better, but in spine it may make it harder for you to operate. They said it makes the bones harder. You may find it difficult to operate. And second thing is, if in a CT guided biopsy, don't start denosumab. If you can get an excision biopsy, that is different, but do not start pre-operative. That I was surprised. I asked them, if you have to in an extremity start denosumab, why not in spine? They said spine primary is surgical. If possible, get a total excision. If not possible, then we'll think of denosumab later. That was their explanation.
Okay.
So any other point of view from Arun or somebody? Sir, Sushil, sir?
No, I agree with you, what you have done. I would feel that, surgery should be the first approach. And debulking and getting rid of as much tumor as possible, and then planning fixation would be the right way to go.
What is the neurological deficit she has, Dr. Apaji?
Nothing.
No neurology. Normal.
No neurology. She came just with a mid-back pain.
Okay.
And luckily, most of the things in my hospital get done within 1-2 days. So I could get a CT scan and a PET CT, CT guided biopsy, report is with me next day. So very fast.
Quick, yeah.
So were you planning for on-block resection?
Yes.
Trying to get, okay, that's what I would have aimed for as well.
So that's what. The next question is, did you see these pictures? So it is now extra osseous, right?
So you cannot do en bloc. This is already exceeding into the canal.
Yeah. So by necking,
you can't have classical en bloc.
Can have a marginal resection. You can do a marginal resection, but I don't know how much it will be possible here.
How many of you will plan for an en bloc? I thought it was not doable with my limited surgical skills. Second thing was, will you do a total spondylectomy, which is more like get the tumor as much as out possible than do a total en bloc excision?
But
so,
if it is GCT, we should, if you have a diagnosis, then it is very clear that we should go for en bloc. That is the thumb rule. But
no, en bloc. My question, Sailesh, is like if you have such posterior element involvement, once you do a laminectomy up to the pedicle, you have already breached the tumor.
Yeah.
Yeah, so this is not amenable for en bloc. If you see classical,
it is,
yes,
it is not possible. This case is
by necking classification, it is involving 3 zones.
Correct.
The posterior, exosseous, posterior element, as well as anterior body.
Intraosseous and intradural also.
Intradural also.
Dr. Appaji, is it a vascular tumor? Does the MRI sometimes, the radiologist?
Yeah, the radiologist said it is not a vascular tumor. So we therefore even that was discussed. Should we do? But once the GCT came, they said no need. Go ahead and just do a surgery
without preoperative embolization.
Yeah. So actually, radiologist felt I went and discussed. I mean, in the tumor board, he said this doesn't look vascular, so you can go ahead and do the surgery.
Yeah.
I will complete spondylectomy, anterior posterior by only posterior approach.
Total spondylectomy rather than an en bloc spondylectomy.
Yeah.
Yes. So how many of you still send the tissue for a frozen section?
So I've done a lot of these, and I did a fellowship in America and Toronto. So I've been involved in more than 40 on-block resections for primary tumors. Now, this patient, she's young. She's 19 years old. It's different if she's 60 years old. So in a 19-year-old, the priority should be to try and get as much tumor clearance as possible. Now, anteriorly, you can usually find a plane and you can aim to try and go around it and get as much as possible, but posteriorly that may not be possible. All of us know that. Yeah. So one of the things to do is to try and do a contrast scan before to see the vascularity of this tumor. And in these cases, any degree of if embolization can help in any way at all, that would really help. And the second thing, what you've rightly done is an intra-op frozen section. So you keep sending the frozen sections and aim for marginal clearance, or you try and get you have to leave areas without tumor. Basically, that is the principle. So by saying on-block resection, what you mean is you're trying to get
total
all the tumor
spondylectomy
tissue out.
Yes.
Take out all the tumor tissue and the vertebral body that is involved, because getting the body out is quite easy. Yeah. But you don't want to leave any residual tumor tissue behind, and the frozen section would help you with that.
Yeah, so Arun, I completely support what you say, and let's see what Appaji has done. Yeah.
So the discussion was two things. One is in a GC. Yeah, Bibu.
Yes,
just one question. So I just wanted to ask the panelists that is there any intraoperative measures or tricks to prevent local seeding while doing, because the cortex is broken. So what are the measures what we should take to prevent intraoperative seeding into the surrounding tissue?
Let's start with Patkar.
Yeah, so one of the tricks is you get the extent of the tumor fully defined, and basically you need a very wide approach. So you expose normal areas above, normal areas below, and then you're almost going for a radical excision. So you're going along the planes of normal tissue and sort of trying to encapsulate it from all around. Now, posteriorly, you may not be able to do that, especially in the midline because of the bony involvement. So you leave that bit right to the very end. So what they tend to do is it's almost like modified tomato technique or whatever. So you go around the paraspinal muscles, get into the chest wall, get the disc above, the disc below, separate it out, and finally you try and break the pedicles off, and then you take out the lamina in one piece, aiming for dural clearance. It is a difficult case, undoubtedly difficult because of the epidural spread, and she's young. You don't want to leave her paraplegic. So maintaining a high blood pressure is also important to ensure that the cord is not underperfused. It's a difficult case. If you've done it, well done to you.
Yes, Appaji, we will proceed.
Yeah. So two points we discussed is, one is being an young girl, we don't want her. I mean, she's walking. She's not come with a neurology, so we don't want to give her any neurology. So IONM, and as Rajesh said, we did mark areas out in the MRI, and intraoperatively we kept on sending frozen sections from the margins. So we use that technique also. But as Arun said, this was a total. The plan was a total spondylectomy. The posterior first, remove the pedicle. The normal side, the left side pedicle was intact. So remove that, make the drill, and then from there peel off the tumor from the dura. Go to the right side, take off the entire tumor. Now stabilize one side and then dissect anteriorly. So this is after removing the posterior elements. The normal pedicle, the tumor, again dissected around, remove the rib, so the lung is also exposed, some amount of pleura on both the sides. This posterior thing was removed along with some muscle, paraspinal muscle, because the tumor had broken the lamina and come out. So when I was dissecting, so we were sure to leave a little bit of tumor, and then that first section was sent to frozen section. By the time we were dissecting around, so this was dissection on both the sides, removal of the tumor side fully, keeping the bony side intact. It was easier to remove the tumor side because it is all loose there. So and then we sent biopsies from this margin. I don't have an access to a tomitasa. I just use the regular osteotomy method into the disc space. So went to the two discs, mobilized, broke it into half, removed one half, then removed the other half. So this is a D11 root being tied up. I use the tag to just pull the dura to one side. So I don't cut it off. So I leave the tags to pull the cord. If at all you have to mobilize slightly. And as much as Arun said, keep the BP high, keep the bleeding less. And also third thing is keep the IONM running all the time. So all the three were being done. And that's the dissection on the other side. It was easy to remove because this was more bony. So you just went in, dissected around the dura, pushed this element back. Again, the disc was removed as a total. That was removal of the entire body with the posterior element, reconstruction with a cage, and I used the rib beyond this, part of the rib beyond the tumor. So I excised ribs from both the sides. So I used the same rib from there, and that's a post-operative picture. The patient, the surgery took almost 2 hours, 2.5 hours, but the bleeding, as Arun said, we could keep it to minimum. She required 2 units transfusion. But not that vascular. It was quite clear. As you can see, most of the fields are quite. And I was using flow seal everywhere. I was just packing with flow seal, wait for the bleeding to control, and then proceed one step after the other.
You are very good anesthetist also.
Excellent.
And so that's the intraoperative picture.
Beautiful.
And pathology came as giant cell tumor. So again, I went back to the tumor board. And they said no more, as the pathologist was there, he said, most of the marginal tissues I sent, except for one tissue, which showed a slight giant cell still present. Most of them are negative for giant cell, except for the tumor side, the entire tumor. But the problem was the medical oncologist felt we should still not give denosumab for a young patient. We will repeat our scans after 1 year if there is even a small recurrence. They said 2% chance of recurrence with a small marginal tumor. So if there is a recurrence, they will give denosumab rather than do anything for this. That was a post-operative X-ray, and I think I got a 6 months, 6 months follow-up X-ray.
Yeah, very well done, Appaji.
Appaji, any
Excellent, Appaji.
connector to be added at that level, transverse connector?
This is a big debate we've been having all through. I feel transverse connector is just an extra metal piece and does not give you, with an anterior cage, it does not give any extra stability.
Okay.
Very well done.
That's my take. I do not know.
Yes,
Arun, please.
So only other tip with these cases is when you have to keep the blood pressure high, you can use tranexamic acid infusion.
Yes.
It really helps with bleeding.
Yeah, we did use Tranexa, and intraoperatively in the field also lots of Locil. So this was quite an expensive surgery for the girl.
Do you give Tranexa infusion or locally wash with Tranexa?
No. We give a continuous infusion in these patients.
Well
we also
done.
follow the same principle.
There is a bolus and a continuous infusion.
Yeah, we'll go to the next.
Even we wash with the Tranexa solution.
Wash
with the infusion.
Wash with tranexamic is very useful in the hip and knee, but there are papers to show that it doesn't help so much in the spine. So
we had
never
a paper.
tried it.
We had a paper from our center, and we have seen there is if we add Tranexa local wash along with the infusion, the may not be significantly less, but it is much lesser than only infusion.
Nice. Well said.
That's published. That's already published.
Yeah, well done, Appaji. We
Thank you.
The next case, the sequence will be now Dr. Himanshu Kulkarni will be showing his cases. We'll have to go a little fast now because the time constraint. Himanshu.
I think I was an express, no? Right?
It was very good, yeah. Yes, Himanshu.
Very nice.
Excellent. Express.
Himanshu, Dr. Patkar wants to present his cases last. So after Himanshu, Rajesh will present, then myself, and then sir, and we complete.
How much time we have got?
We have time till 8, sir. 8 o'clock is our official time. 8:15 we can come.
So 15 minutes each case.
Yeah. Quickly, yeah.
Okay. Shall I go ahead?
Yeah.
Yeah. So this is my case. First case is it was a 34-year-old male, low back pain since last 2 months, no lower limb radiation, no difficulty while walking, no history of trauma or fall or fever or weight loss, no constitutional symptoms as such, no bladder bowel disturbances. On examination, the tenderness was precisely at upper lumbar. It was midline tenderness. Forward bending was painful. Reflexes were normal and no sensory loss. And motor also, you can see it is absolutely normal. There was no neurodeficit as such. Blood investigations, HB was fine. TLC was 6,600. ESR was slightly raised. It was 28 and CRP was 1.9. In radiogram, as you can see, if you see carefully in the plain radiogram, you can see that winking owl sign at L3. You can see the left L3 pedicle is absolutely restricted. You cannot see the pedicle in the X-ray at least. So we got the MRI done, and this was the picture in the MRI. Dr. Appaji, sir, what's your opinion about the clinical features and the MRI? Would you like to say something?
Yeah. This is one case, Arun, where we will think of TB because of the contiguous lesion, and there is a slight anterior, there is too small. But one thing which is striking is the marrow replacement inside. So it does not look like TB to me. It's not a destruction or a marrow replacement. There's a marrow infiltration here. So looks like a tumor to me rather than,
Tests are involved.
Okay. Vibhu Mohapatra.
Yeah, I will not go in favor of infection. Yeah.
Okay.
So some kind of tumor. So
the lesion at S2 also, the sacrum is also involved.
Yes.
The sacrum is involved. The
multiple areas
is involved. even the posterior elements of L1 is
Are
also
involved.
involved.
Yeah. Yeah.
As you can see, look at the mid-sagittal T1 image, you can see the marrow edema is extensive. It is at L2, L3.
L2,
You
yeah.
can see the corner of D11, which is also involved, and S1, S2. So there, none of the discs is involved. There is only marrow edema at multiple levels.
Yes,
And
yeah.
this is the axial cut of L3. So you can see the left L3 pedicle is completely destroyed, and the anterior half of L2 is involved.
Blood investigations.
Yeah, so this was the MRI. So MRI showed multiple lesions. So there was a lesion in right side of D11 vertebra, L2, L3, L4, and there was also a involvement of left iliac bone.
Right.
So according to the MRI report, there was a possibility, obviously, of the neoplastic etiology, such as metastasis or lymphoma, which is most likely. That's what they said. So the primary orthopedic surgeon referred the patient to the oncologist. So obviously the differentials, probably you all are thinking, are skeletal
What was the age of the
metastasis
patient,
or
Himanshu?
34 years, sir.
34.
34 years.
So multiple myeloma is unlikely.
Yeah. So that is differential number 2. So skeletal mets or multiple myeloma, least likely is multifocal infective etiology. So with the oncologies, all these things, because at our place, the PET CT is not very easily available. So the things which were done was USG abdopelvis, which was normal, HRCT chest, normal, PSA was done, which was normal. So thinking of myeloma, also bone marrow aspiration was done, which turned out to be normocellular, and myeloma profile was normal. So what next now? How should we go for it?
Biopsy. You said there was a lesion in the iliac crest, no?
Yes, sir.
But then instead of doing bone marrow, you taken directly from the iliac crest.
Yeah. So since all these reports were negative, patient got a little frustrated. He came to us for the second opinion. What we did was L2 and L3 transpedicular biopsy from both pedicles. We got 4 big chunks.
Okay, well done.
And Dr. Ranganathan, as you had mentioned before, in India, it turned out to be TB. So on a transpedicular biopsy, it turned out to be tubercular osteomyelitis.
Multifocal cause.
Yeah.
So it was multifocal cause. Then we got into literature. There are a lot of reports are multifocal cause. So multifocal tuberculosis mimicking multiple bone metastasis. So
you bold everyone.
Like metastasis. Sir?
You bold everyone.
The patient bowled us actually. The oncologist, first orthopedic surgeon, and then we felt like a hero. Yeah, we diagnosed it. So it turned out to be multifocal extensive tuberculosis involving 5 levels or so, non-contiguous. Disc was absolutely not involved.
Yeah.
So in India, actually everything mimics TB and TB mimics everything. That's, you always have to think about TB first whenever you are stuck with something.
Said, well said.
With standard protocols, which are done in 2017, we went for 1 year of AKT, 2 months of intensive, and 10 months of continuous phase. So
that is why I feel in India, if there's any lesion accessible, biopsy it first. Don't waste time doing UAG, CT scans, abdomen, CT scan, chest. If the lesion is accessible, you got to diagnosis next day morning.
Yes.
So if you don't have a PET CT, you should have gone for a biopsy.
Yeah. So whatever the diagnosis or treatment protocol you are deciding, it should be based on tissue biology or the tissue diagnosis. That should be your first protocol. That's what I feel. So you can see at 1 year after AKT, the lesion is completely healed.
Completely gone. Yeah.
Absolutely a tuberculosis.
Excellent.
Excellent. Next.
And next is a pretty straightforward case. 50-year-old male patient, severe neck pain, severe stiffness in 5 days. There was severe neck pain and stiffness, complete restriction of neck movements. He couldn't move his neck at all. So there was no history of upper or lower limb weakness, bladder bowel disturbances, no history of trauma, fall, fever, or weight loss, no constitutional symptoms. He consulted a local clinician. Since there was severe stiffness, he was on analgesics and muscle relaxants since last 3 days, but there was no relief at all. So on examination, there was complete restriction of neck movements, bilateral trapezial tenderness, reflexes were normal, no sensory loss, no motor loss, no neurodeficit whatsoever. So this was the picture. Investigations, HB, TLC, ESR was normal, CRP is normal here. So on the X-ray, this was the picture. So there was severe spasm, loss of cervical lordosis. Disc spaces, as you can see, there are absolutely maintained. So there is no collapse of disc space, or you cannot see any bony lesion here. So you can see up till C6 and C6-7 disc space is visible. So we couldn't get anything with the X-ray. We got the MRI done. So this was the picture. So X-ray was a little misguiding. So there was a collapse of D1 vertebral body. minimal cord compression. The patient was probably fortunate not to have a neurodeficit with this setup. And it was, according to the MRI report and whole spine screening, which I don't have here, it was a solitary lesion with no other vertebral involvement.
Age of the patient?
Age of the patient is 52.
52, okay.
52 years.
Severe
on axial kits, you can see retropulse fragment, but it is with minimal canal compromise.
The junctional level compression. Oh.
Yes, sir. So lytic lesion at T1 and near total destruction of T1 body. On CT, you can see.
Tell us what you did, Himanshu.
Yeah, so on investigation, chest X-ray was normal, myeloma profile normal, as expected. PSA was 70, and USG abdo-pelvis showed enlarged prostate. So we got the PET CT done here. PET CT showed only 2 increased uptakes. One was in prostate, and one was in a solitary lytic lesion at T1. There was no other metabolically active lesion all throughout the body. So according to modified Tomita grading, this was a slow growth tumor, probably prostate. Visceral metastasis were 0 and bone metastasis was solitary. So the score turned out to be 2. So there was a point in going ahead with surgery. So the score was 2. We went ahead with surgery. And we already have discussed the scoring part. So a lot of debate is there, which score is good, which is not. So I won't go that into detail. Dr. Kothari sir has discussed this in detail. So what we did was T1 corpectomy and C7 to T2 fusion. So that's what the patient fortunately had a long neck. So we didn't have to excise the medial clavicle or sternal split. So we got away with regular anterior approach. So what we did was T1 corpectomy and C7 to T2 fusion. And the histopathology turned out to be adenocarcinoma. So it has been 8 months now. The patient has undergone hormonal treatment. He has undergone orchidectomy and prostate resection because he is doing well. So what I feel is for regular orthopedic surgeons, what X-ray could always be a thing that can disguise you.
Neck pain, yeah.
If it is that severe, you have to investigate the patient further.
I think prosthetic mets are sclerotic mets. So I think there was overlap of the shoulder and the rib cage. That's why we couldn't see that.
Yeah, we couldn't see the C7.
Otherwise, had it been a higher, I think prosthetic mets are sclerotic mets. So it's to diagnose them on X-rays.
Yeah.
Well done.
And the other thing is in the pre-operative X-ray, if you draw a line from the manubrium sternum, it goes to T2.
Yeah.
So that's the reason why you are able to reach the T2 anteriorly very easily.
Yeah. So he had long neck and it was exactly intersecting at T2. If it would have been a little higher, we might had to excise the medial clavicle or something.
You have to take the patient on the X-ray table pre-operatively, put a bolster under the shoulder like you are going to do in the OT and do an AP X-ray.
Okay.
Only that will tell you. But I'm not worried about the X-ray. What is important is to study the arch of the aorta and the innominate vein on the MRI at what level it crosses.
If
it is crossing higher up, it can cross right up to C7 sometimes.
Yes.
Yeah.
And that is the time you can come in deep trouble.
What precautions you will have to take if you have to go for this approach?
I told you that the MRI, you should study the arch of the aorta and you must study the innominate vein. Second thing, I noticed that you operated from the right side, that is asking for trouble at this level for recurrent laryngeal nerve injury.
Yeah. That
incision on the right side. And that is not acceptable if you are going below C6. What do the other panelists feel?
I think I always go from the right irrespective of the level because that's...
I think Dr. Patkar has a very valid point. Valid point, you know.
Absolutely agreed. So the course...
Parasite, what would you do? Would you operate from right or left?
Left, sir. Below C6, always left.
Below C6, nobody would operate from right side. Because it's a preventable complication.
Yes.
It is a preventable complication. Once you get hoarseness after operating from the right side below C6, you have no explanation.
Yeah, just one more question to the panelist. CA prostate with a solitary maid without having any neurological deficit, many of these patients do become pain-free with the hormonal treatment.
With orchidectomy.
Most of them, if this patient primarily would have seen a neurosurgeon or an oncologist. Many of them do not come for surgery and do exceedingly well.
If they come early,
So here, Himanshu, probably what you are correctly addressed is the pathological fracture and instability arising from it because it's a junctional area. That's the message to be given, not the message that a medicine that you operate. Majority of this do not.
Instability has to be taken into consideration.
Well done, Himanshu. Really very nice cases you presented. We would like to go to the next stage. I would like Rajesh to share his screen.
Yeah, Himanshu, you need to stop sharing.
I'm just ending it.
That's the reason we thought of keeping this session as lesions in spine, infection, non-TB, TB, anything, okay, there are a lot of interesting things.
One more point I just wanted to stress in first case. In first case, the ESR and CRP are absolutely normal. So when regular orthopedic surgeons, we always stress on ESR, CRP, and this could be an inflammatory pathology. So it is not always like that. That's what one message.
Another thing, may I ask you, when you excise the tissue, did you reconfirm from the excised tissue it was CMA? I had a couple of cases, it turned out to be porotic fracture with another involvement of severe prostate or something. That is also possible at times. So always when you excise, do not feel that since you already have a prostate down or some other biopsy or urothroscopic biopsy, always take all the tissue for again and again reconfirming.
Absolutely,
yes.
On the contrary, Rajesh, we had done couple of cases which we had thought to be osteoporotic, and it turned out to be metastatic, infective and tumor. So you can never be sure until unless you have the histopathology from that site.
Shailesh, I will just run through. You tell me whether to stop.
I think you run through now.
Sorry, I interrupted you, Ajay. Should I go forward?
No. Please go ahead, sir. That's why I said.
Mine are simple cases. No googlies like extensive this thing like that.
Yeah, we will run through so that we can ask any questions to Rajesh at the end of it.
Sure. So this was a 22-year-old lady. She presented somewhere else initially with neck pain, imbalance while walking. She was treated locally, just symptomatically at neck spasm, no relief, kept on worsening. So the person did a X-ray. Now you can see a lytic expansile lesion at two contiguous vertebrae, C4 and C5. Also on the AP, you will see the sideways expansion close to the facets as well. Again, treated symptomatically, no relief. So MRI done. You can see a hyperintense on T2, hypoisointense on T1. Expansile tissue going into the canal, cord compression. The patient was neurologically intact. So the first person who was treating probably thought of still doing a biopsy. Anybody else wants to have any other management at this stage? We do not have any other investigations. You can see this picture, and then she was done a posterior open biopsy through a small paraspinal incision. It was not deburred. There was no decompression done. The available report with the patient was aneurysmal bone cyst, following which again the patient was put into a collar. She worsened further. Then she came to one of my teachers and senior colleagues, Dr. Karuna's hospital, where I was calling for. That time she was presenting only with her established myelopathy involving both upper limbs, lower limbs, classical cervical myelopathy, no bladder wall involvement. She was not able to do any kind of ambulation without support. Extensive neck pain persisted. This was the picture. You can see compared to the last X-ray, there is a pathological collapse of the C3 vertebra. C4 is still expansile. This is the picture compared to the last MRI, extensive involvement, increase in the soft tissue. On the right side, the soft tissue is going around right from the anterior part of the vertebral body to the spinal stiff process. Cord is pushed on one side. The deficit at this stage was more on the right side. Vertebral artery was also engulfed by the tumor tissue. Anybody wants to just comment on quickly how you will proceed further? We have a diagnosis.
Yeah, we'll ask Patkar, sir.
Yes, Dr. Patkar, sir.
This requires both anterior and posterior surgery. First, I would go in for the posterior surgery, do a good decompression. In my presentation, I'm going to show something similar.
Okay.
So let's get on with it. Obviously, it requires decompression. It requires fixation.
Yeah.
You'll have to do a good CT scan first to see the adjacent bone levels, bone stock.
Yeah.
What kind of bone is available to you for fixation, both above and below. There is no question that you'll have to do both posterior and 360 degrees.
Yes, Ajay.
Parasnis. When I was doing my fellowship with Human Harms, so we used to do they used to do lots of cervical spine tumors with vertebral artery compression, as you said, on one side. They used to do something called the block test of the vertebral artery on the other side.
Yeah. Dr. Hans always had a vascular surgeon in the same premises. He was lucky.
Yeah.
Okay. Do you also do a block test?
Not, I didn't do this because the place where we operated, did not have the facilities, but a DSA is extremely important. So the point is well taken. Dr. Appaji, what you want to say that these are extremely vascular tumors?
Yes.
Close to the vertebral artery, not just the artery, but the surrounding vascular
also. Yes.
extremely
I would
precarious
from you.
right? So going in at this area is very different from going in, let's say, at lower thoracic thoracic morothoracic. Point well taken. So here probably the tumor tissue is not such a fear as much as the blood loss, and you do not have a direct control. So beware of the vascularity. Should I go ahead and show what was done?
Yeah, go ahead. Go ahead.
The CT showed good amount of bone stock, so we decided to go in both posterior and anterior. As Dr. Patkar has rightly commented, this is a 3-column destruction. You have to support it both posterior and anterior. Only one side is not going to help, and you have to go around the neural tissue as well as the vascular axis. So preoperative embolization was done. There was no single feeder, so they used the flex with multiple small feeders, and we had to operate within 12 hours of the embolization. It was done 2-stage, first posterior, fixation above, below, debulking the tumor, seeing the cord entirely. We did try to go close to the vertebral artery, but didn't fiddle with it, because I don't have access to vascular surgeon, neither I have the acumen to handle if anything goes wrong. Turned the patient, did anterior tumor excision, 2-level corpectomies, and from C2 to C4. This was the intraoperative CM images. This was the histopath, again reconfirmed aneurysmal bone cyst. This was the picture on 10th day post-operatively. Patient was mobilized, sent home that same day, showed excellent neurological recovery in the short term. By 6 months, she had good mobilization, good movements restored. She recovered neurologically entirely, and the graft was also showing excellent. So this was a case which went beyond our expectation, that there was not much blood loss, and it was well under control. Again, thanks a lot to the anesthetist and my OP team and everything, because sometimes you may land up in future. So just to summarize, should I go ahead, Shailesh? You want to ask?
Yeah, I think just go ahead, Rajesh.
Yeah. So this is about ABC. Typically, posterior elements move into the vertebral body and can become osseous expansile destructive lesion. 75% times younger than 20 years age. Radiographically, it's expansile osteolytic, as you saw in this patient, bubbly appearance. Cortex is often eggshell, and it just blows out. When you remove these tumors, also it just comes in hand. MRI and CT, you can see the fluid levels, as in this case you could see on the MRI. Now, what were the options? Intralesional curate, because there was no wide local margins to be attained. It was already pathological fracture and everything was out. If it is contained, complete excision, as much as possible remove, because to reduce the recurrence, as much as possible you need to remove. Instrumentation is required to address the instability. Afterwards, radiation therapy in extensile cases is recommended, but it can give rise to secondary malignancies. In this case, we did not opt. We asked the oncologist, did not advise. Embolization is a must. And other than the surgery, sclerosing agent or denosumab is an option, but this is only for contained cases. Beware that if it is very close to the cord, it can cause disasters. How much and all, I will not go into the detail because time doesn't permit. Denosumab is another option. It clearly says it's not a substitute for surgery, but it can help, especially if the neurology would have been normal. I would have definitely liked to try, because it's a very extensive job around the neck to go 360 degrees. So this has to be kept in mind. This is one option, but anteroposterior reconstruction and as much complete excision of the tumor is a must. Dr. Karne has a good follow-up of this patient, almost now 6 or 8 years, and she's doing quite well. Should I go to the second case, Shailesh?
Yeah.
So this was another patient, a 35-year-old male presented in 2011 elsewhere. Initially, symptoms were just back pain without any neurological problem. Was treated symptomatically, kept on getting progressive pain, no response. So the first MRI was done in 2011. So there was a lytic lesion to start with a D2, anterior plus posterior without cord compression. PET CT was done. Now CT mentions it is a hypermetabolic lesion. Could be COX, could be neoplastic. Go for biopsy. So promptly a biopsy was done by another colleague of mine elsewhere. I was not in the picture that time. It turned out to be a inconclusive lesion, and many times this is a fallacy. I do accept, even like other senior surgeons are commenting, that go in for biopsy, but you get foxed when the biopsy doesn't give you a conclusive evidence, and that's the time you need to keep on assessing the patient entirely. Now that time the patient got fed up of the investigations, just left. He's from another place, Akola, went there, again came back with persistent pain and progression of the pain, and that is the time, this was the first time I saw him. Compared to the last MRI, the lesion was progressive, both anterior posteriorly. Now this time it had involved a contiguous vertebra, and there was intracanal tissue. The CT clearly showed lytic lesion, anterior as well as lateral, more on the left side. Canal compromise was there, but neurologically was okay. Again, I gave an option of repeat biopsy and further treatment. Patient got scared, ran away. Now he comes back 2 years further in 2016, and this time he came because he had deficit. He was not able to walk without support, instability, hyperreflexia, classical myelopathy signs, girdle signs, progressive pain, and slight prominence in the back. This was the MRI 2016. This was the CT that time. Sorry, I have just crammed up all images thanks to my assistant, but you can clearly see in the CT actuals a huge tumor now. On the left side, it is even compressing the lung fields, hardly any cavity, filling of the lungs on the left side from D1 to D3, extensive involvement in the canal, cortical perforation, pedicular destruction, going from the anterior to the posterior, as well as quite a bit of tumor is on the lateral side. So at this stage, patient was willing to undergo any procedure that you recommend. The first thing promptly that we advise again is a PET CT followed by biopsy. A PET CT again was not very conclusive, but at least they committed that this is not TB. This is a low-grade neoplasm. But obviously for the tissue typing, we need to undergo biopsy. Fortunately, there was no other lesion. There was no dissemination. It was localized to the same area. So we took a biopsy. I'll go ahead, Shailesh.
Yes, go ahead.
Rajesh, why did you only go ahead with biopsy? The patient has gait instability, neurological deficit. Why not decompression and stabilization and biopsy and then second stage?
Yes, Dr. Devu. I mentioned that the patient had grade 3 to grade 4 power. He was ambulatory with support, no bladder coil involvement. This is a slow growing tumor from 2011. Patient was ambulatory. So sometimes I take grade 3 as a cutoff power. Second, for the purpose of treatment strategies, I need to know the tissue type. I need to know the tumor type. And I have time in hand. This is not a very rapidly progressive tumor. So I put him on steroids, admitted him, and then did the rest of the things. I involved the oncologist. The first thing is always, since the last biopsy is inconclusive, on what basis I am going to plan. This could be anything from a low-growing sarcoma to any primary malignancy over there that we don't know about. Right? So it was not an emergency from my point of view to rush in. So we bought 3 or 4 days during which completed these investigations. Is that an acceptable reason? That's what is recommended in most.
Yeah. Sometimes the biopsy also takes quite a long time. If from a bony tissue, it can take around 2 weeks.
Usually 72 hours is what we do.
There is a lot of soft tissue component in this tumor. It is not going to take a lot of time.
You're right, sir. When we pushed into the posterior cortex, the core was of clot plus soft tissue type. It was not a bony core as such. So we got the report, and this was the report. It showed low-grade spindle cell neoplasm. So something like a low-grade malignancy. Now we had to do the literature survey. We need to ask the tumor board. We need to go through all the references because we do not know the behavior of the tumor. But one thing was certain, that it required a complete excision, as much as possible, complete decompression stabilization. Just like the beautiful case what Dr. Appaji showed, we did almost similar. There was no role of en bloc over here when it is already with so much of expansion elsewhere. Second, going anteriorly in front of D1 and D3 has a lot of morbidity. Plus, still I would not have been able to do an en bloc. So we decided to first go posteriorly, remove as much as possible, and only if I was not able to address, I had counseled the patient for the need to go anteriorly. So single posterior midline, bilateral rib excisions, 3-level fixation above, 3-level below, complete bilateral extrapleural excision. We went around the tumor margin, piecemeal we removed the entire tumor and placed 2 cages anteriorly, 3-level fixation with a cross connector. This is an intraoperative picture. This was the post-op day 1. Patient did well. Neurologically, he started showing recovery after 48 hours. The report later on, HPE still they adhere to the same. Benign or low-grade aggressive malignancy, spindle cell tumor. We took a second opinion. They were not so clear. They suggested query fibrous dysplasia, query spindle cell malignancy. So again, we had to ask the oncologists about further adjuvant treatments. Now, this is where I want to highlight the fact that many times as surgeon, we are dependent entirely on the histopathologist, sometimes pre-surgery for the strategy, and post-operative also. If something goes wrong with the diagnosis, we can make a wrong strategy. And second are the radiologists. So you need to have clear delineation. Here also I forgot to mention, prior to surgery, we did a DSA. Fortunately, the tumor was not highly vascular, so there was no need for embolization. After 6 weeks, one of the cages showed dislodgement from the inferior side, but patient was asymptomatic. So at this stage, we were having a little apprehension and we are not sure what we should do further. Ajay, you want to comment whether you should do anything 6 weeks post-op? One of the cases at such kind of surgeries post-op is showing a little dislodgement.
I think,
yeah. Please, Ajay, go ahead.
Yeah, I think we should just observe, because again, digging at that level is going to be a problem. So we should just observe him, and I would protect him at that particular time. And
any particular kind of prosthesis?
I think I would give him Somai sort of brace.
Right.
Somai
brace is thermo-oxygenated
Somai or a CTO, whatever.
prosthesis. So you need to customize a bit. Most of the orthoses are either for subaxial spines or from C1 to C7 or lower down, as we have many. So here you need to have a little more support, a guarded mobilization regime. Dr. Bibu, you wanted to add something?
Yeah, just little skeptical about 2 cages at such a high level. So I'm not commenting on the surgery, but because at the higher level dorsal spine and cervical junction, this space, the body size is quite small.
So yeah, so I have chosen 2 small cages of instead. So this will 12 mm instead of a 16 mm or whatever.
My suggestion would have been put in a little larger cage, but 1 cage and little more central.
I'll tell you why.
So the possibility of disengaging of the cage, keeping it lateral, would have been little less. That's
so this is all retrospective. I do accept the comments, but I'll tell you intraoperatively, lateral to the cord, you need that much space for the cage to go parallel, and then you push in anteriorly.
Correct.
So we tried here. The retraction was so subliminal. Remember, this is apex of the rib cage. Right. So you can see with even after the rib excision, there's hardly any place. So we were getting difficulty to place a larger cage.
Yeah, I think
relying on a smaller cage just centrally was not an option. That's why I chose this, and it appeared to be a good, solid construct. So intraoperative, we were not worried about anything.
This is a practical difficulty, as Rajesh is saying. If you think we can put an anterior very good cage, but this level is such, it can be difficult. We are worried about the cord. Probably putting 2 small cages and giving a good support is a second, backup option. So what you said is right. But
how many
what
roots
was
did you have to sacrifice, Rajesh? Did you sacrifice 2 roots or only 1 root?
I sacrificed D3 and D2 on one side. D3 bilaterally and D2 on one side.
D2 on one side. So if you sacrifice more roots, even if you sacrifice D2, D3, it is easier to get the cage inside.
No, so it was not about the roots. What was happening is it was coming very close to the cord, because laterally I was not getting enough space to go in, just parallel where you go in. We tried this a lot. I've done multiple. I have done more than 25, 30 cases with 2 cages and more than 120 cases with single cages. So I'm conversant with both. This particular patient, I was finding difficulty to push in and then push in medially. Right? So I thought that why take a chance where it can get good results, right?
But now the right-sided cage is almost not in contact with the lower bone; it is outside.
Right. So this was exactly 2016 midway, or
it has remained like that.
No. That was 2016 start. Midway, sorry, late this thing. This was
2017 March.
Right. It's the same position, sir.
Good,
now,
very good.
No. See again what has happened. That cage is not completely out of contact with the inferior body. Even if it goes a little laterally, there is still that ribhead plus.
The superior end plate is there. It is hitching on it.
Yeah. So we were watching all the time. And it is this entirely sometimes your surgeon's experience and your and your visualization.
Yes,
so what was more important than the physical construct is what happens to the tumor mass, to the neurology, to the overall life expectancy of the patient. So we did all sorts of referencing. We took second opinion from Tata and everything. Everybody said whatever needs to be done has been done. Short course of radiotherapy followed by chemotherapy. This was done. We did all the sequencing. These are rare tumors, not much data available, and you need to do surgery followed by chemoradiology, the lower one, right? So these are low grade to intermediate grade connective tissue. You can say malignancies or aggressive tumors. If that spreads extracapsular, then is a problem. Intracapsular, you can do wide local excisions, but it needs surgery. And if it is extracapsular dissemination, post-op radiation chemotherapy. As I said, limited data about the prognosis. Now, this was 4 months post-op, CT as well. We kept a watch. We kept a watch on implants. That's why CT was important. This was for post MRI also along with CT this thing. Neurology was excellent. There was no tissue left. This was 2019 follow-up. I spoke with the patient today at 12:30. I want him to come back again. But you can see everything is the way it should be.
It is, yeah.
Now we know the problems of assessing radiological fusion, but it will be almost 4 years in a few months. Patient is asymptomatic, neuronormal, not even willing to come back for follow-up because he's asymptomatic, put on weight. Oncologist has given a great clear signal, but he has advised him when to do PET CT, when to follow up, right? One thing I want to talk about this is the surgical management of these tumors is extremely important. Do not try, this was entirely done by me and my colleagues, very important for the surgery to have experienced consultants with you, but no need for any specialized oncosurgeons or vascular surgeons or general surgeons. You give excellent results.
I think excellent surgery, and I think the most important part the most important part that I think that the surgical wisdom helps here is, even after you saw the cage just migrating a bit posteriorly, you still held on, and you thought that let the fusion happen and we would win the race. And I think here's where the experience come into play. Otherwise, what's happened is
if this would have been thoracolumbar or a lumbar, you know the problems.
Absolutely.
This is part of the thoracic cage. Still there is anterior sternum. Still there are posterior
because
these get fibrous very fast. And we have 3 level good solid fixation. So that's why to tie.
I completely agree. It's very well done surgery and a good follow-up, and what all our concerns are there. And we look forward for a good work from Arun. Thank you, Rajesh, for excellent cases.
Thanks,
as the time.
Excellent, Rajesh.
Yeah, Arun is presenting a quick cases. Dobara mat puchna, no questions for the master, and then I will present, and Dr. Patkar sir will complete the sequence. Yes, Arun.
I just sort of showing you a very quick case. So I just took a 2-year-old patient who presented with neck pain and dysphagia. And
you're not sharing the screen?
So it's basically a C1 to C3 chordoma with bilateral.
Arun, you have to share the screen.
Oh, sorry. One moment. Are you able to see?
Not yet. Yeah. I think you start. Yeah. Yes.
Can you see the presentation?
Yeah.
So just a very quick one. So this a 59-year-old patient with neck pain and dysphagia. So she had a C1 to C3 chordoma with bilateral vertebral artery involvement. Just one question alone, Shailesh. Am I allowed?
Yeah.
What would you do?
No, I think only neck pain, but this is going to definitely create trouble. We need all the investigations for sure, but this will go towards surgery.
Yeah, and what would you do surgically? I mean, what would your approach be?
I think this needs anterior surgery for sure, because this needs complete decompression and front and back probably stabilization, anterior plus posterior. I'd like to ask Dr. Patkar, who does extensive work at this level. Yes, sir.
Decide after looking at the CT scans. Essentially, the problem of chordoma at this level is the problem of atlantoaxial dislocation whether the facets are involved or it's just the body that is involved. Can you transfer the weight from the C1 onto the body of C3? How much bone is available below the tumor in the C2? All this will decide what kind of surgery you can do. And I think that this is easily amenable to anterior surgery, retropharyngeal, submandibular. But of course, after looking at the CT scan, what is the bone stock? In chordomas, we all know that it's just a matter of time, how much tumor we excise. There's only one treatment, that is surgical excision.
Yeah.
Anything else is, just maybe palliative, like proton beam therapy is there on the horizon, but still the best results are with good surgical excision.
Yes,
what did the CT scan show?
And the main reason I presented is because both the vertebral arteries were engulfed in the tumor.
Pardon? I can't hear you.
So both the vertebral arteries were engulfed in the tumor.
That's all right. Most of them, these tumors are soft and suckable. Even if they're engulfing the vertebral arteries, as long as on the angiogram, the vertebral arteries are not obliterated, these tumors are usually mucinous. They are not very great surgical challenge. The challenge is the crevices where they get into. They're most of the time suckable. They are not solid tumors. They're suckable tumors as if like, mucinoid.
Yeah, so I mean, normally when we do chordomas, we try not to get into the sac because the risk is then you seed it. So you want to go all around it, meaning you want to try and keep the surgical field as clean as possible. So
yeah, look at the margins of the tumor. Is that going to be possible? The margins of the tumor are such that you will have to enter the tumor, start sucking and dropping, and it's going to be come out with your suction. Anyway, what did you do for that?
What did you do, Arun? Yeah.
This is what we did. So we decided to do it stage front and back, like you suggested, submandibular split. In the first stage, we did, all posterior surgeries. We did a vertebral artery bypass, so you can flip the tumor with the artery, and instrumented from occiput to, I think it was C4, C3. So that is the vertebral artery bypass. And then from the front, we did a submandibular split. That is the whole tumor. And we used a pre-vascularized fibular graft to augment it. And this is sort of 3 years post-surgery. I'm sorry, I didn't want to go into the details of the operation, but I just thought, I mean, you can't use a large stage in this.
What were the vertebral levels involved by the tumor?
So this is, so it's involving C1, C2, C3. And so this was something I did a long time ago. So this is C4 vertebral body, if I remember correctly.
Can I have a look at the MRI again? C1, this is C2 or this is C2?
Yeah, so 2 and 3 are destroyed. So we went up to C4.
C1 was intact. You got a CT scan on the patient? That would tell you better.
We had to sacrifice C1.
Yeah, I must compliment Arun for the overall excellent outcome. Anyone else would like to say anything? Appaji.
This is very specialized, extraordinary work.
Yes,
yeah. Sailesh.
Yes.
Yeah, C1 arch preservation or nerve preservation is an intraoperative. As Arun said, if you have to sacrifice, you have to go to clivus. I've seen only one more presentation like this, the Chinese fellow, your friend, Ketan's friend, I forgot his name.
Yeah.
He had come to Pune, like last time.
Jian Zhao, yeah.
Yeah, Jian Zhao. So they make a plate now, 3D printed implant, specifically and fill in. Very good surgery, Arun. I think I would have shat in my pants.
So that was just tubular plate.
Yeah.
Well done, Arun. We will proceed with a few cases.
Just, Shailesh, can you
Yes.
just allow me one question? Arun,
Yes.
can you just tell me the sequence? You went posteriorly first and stabilized and went anteriorly, or you first exercised anterior and then you turned?
So posterior first, because we were worried about the vertebral artery. So you de-roof, expose the artery distal to the tumor, and then you bypass, use a bypass. So obviously it was many teams involved. So there's a vascular surgeon, there's Max Stack. It was just a team approach.
Excellent work, Arun. We would like to go ahead because we have little less time. We have to cover up a few things. Is it okay to share the screen, Arun?
So you want me to do it again?
No. Is it there? Yeah. As this webinar was mainly to cover up a few interesting topics, and we wanted to show array of different surgeries, lesions in spine, and how we treat it. I will be showing few cases of all these our experiences, but it's mainly for understanding that different approaches, different ways to skin a cat, but trying to cover up most of the possible routine practice tumor cases in our routine practice. We'll start with 37 male comes to us, referred by orthopedic surgeon, back pain, persistent, not getting better. All these investigations, only vitamin D was less. All the investigations were done there and they referred it to us. What next? And this is a very common scenario which we see, and we discuss, we diagnose this as a hemangioma, and this patient was posted for a vertebroplasty. Patient was in a lot of pain. When we saw, we thought, okay, this is one of the very commonly seen issues in our practice, and we thought of giving some rehab, physio medications. And as there was no neurology, there was no long track science, we conserved, as we all see a lot of hemangioma. Sometimes there can be some amount of compression and then destructive lytic lesion, then we need to consider surgery, but there was nothing like that. We continued with medications, he improved, and there was no need of any surgical intervention. Patient went home happily, and now almost 1.5 year follow-up we have with this guy. 27 male comes to us with back pain. Again, this was a long back, 8-9 years. We did a MRI. It was sent to us again by our friends from periphery for TB, and this patient was started on TB treatment. There was 3 to 4 months of AKT was given, and we suspected this was not looking, as the patient's pain was not getting better. And this is what the CT we did, and it looked like a lesion, posterior element, looked like osteoid, and which was extraosseous, which is a very rare entity. If you see, it's in the foraminal region, pedunculated lesion, which was very, very uncommon. Because we didn't want to miss, this is a 2010-11 case, 10 year back we did this. We wanted the exact level. We normally confirm it either CT guided, or we confirm it pre-operatively only by doing the X-ray marking, so that our level and incision is very, very precise. And on table, we really got into the foramen, where we did unilateral approach, and we went into the tumor, which revealed us the osteoblastoma. We did a unilateral approach, and as we have 8 to 9 year follow-up, we published this, which now almost 9 years, and the patient is completely symptom-free. There is no pain at all. A very, very unique case, which we felt was in our practice. Again, 30-year-old man comes with back pain. Night sleep was disturbed due to pain. And I'm talking about different cases which normally come into our practice. This is the blood investigations, and this is the tumor again. Persistent pain, not getting better, and turn out to be a giant cell tumor. Given all the, this is again an old case. There was destruction, severe pain, all the things. Biopsy proven. Denosumab we already discussed just now. We normally prefer to do embolization in most of our tumor series. We discussed with our radiologists. And pre-op and post-op, if you see tumor was embolized, we went front and back. We did a complete corpectomy, anteriorly excision, and then we turned the patient. In second stage, we flipped it and did a posterior. We put a rib also at that level to just support on the side, and he's really doing fine. Very good outcome. The pain is completely gone. We are closely monitoring him for the recurrence, as it is important. And again, we have a tumor board, as Appaji was talking, and we take the opinion of them, oncologist team, and as per that, we plan for the subsequent treatment, whether they need denosumab or radiotherapy. In the past, they used to consider, but nowadays radiotherapy is not on the mark for GCT. It is all denosumab which is been considered. 43 referred by gynecologist, known case of CA cervix, severe back pain and instability, difficulty to stand, advanced uterine CA. And this was her clinical scenario: weakness in the lower limb, inability to stand. When she came to us, she was practically lying on her chest, as she couldn't lie on her back. That bad her pain was, all the parameters, as this was known. And this is what was the case. She was almost in the, as per the oncologist, they were not anticipating. Again, this is 8-9 years back. A patient presented to us with weakness and deficit. All this, what Appaji was showing in this particular lady, she had underwent all the chemo cycles, everything was done. This was the onco, and large hypometabolic lesion involving cervix. And all this scoring, as we just do it for our documentation for most of our cases. There was radiation which was given, which didn't respond. The patient was a business family, and they were not very keen for very aggressive surgical treatment, as they were very scared for spine surgery per se. And when this patient was in this pain, then they told us to do whatever, but the safer option we want. And we said there is nothing like safer, because there is already a weakness in the lower limb. There are chances that you will worsen. All these things, we always think about palliative, intralesional, or en bloc. And that time, in view of her all the other morbid conditions, we did decompression and stabilization. She survived for nearly 8-9 months. That was her last follow-up to us. She started sitting, and her pain was significantly better post-surgery. Again, 65 man with Kothari multi-level fractures, was getting treatment for osteoporosis and in terrible agonizing pain, 1.5 months. If you see Kothari multi-level fracture, compression, weakness in the lower limbs. Again, these are the challenging cases. We always want to understand what could be the pathology, how we should go ahead, what should be the option. And they are a little challenging when they come to us. We planned for decompression with all the parameters revealed. It was myeloma, and we fixed him. And now it's almost 2 years. He's underwent bone marrow transplant, and he's completely fine. He comes to us in frequently with some amount of back pain. Now it's nearly 1.5 year follow-up which we have of this patient. Back pain, again, weakness in the lower limbs. This lady was operated for CA cervix, and she was treated with radiotherapy related to orthopedic surgeon. Again, conus level compression. They are again challenging cases where we have to really plan well, and a systematic planning, because this needs anterior reconstruction in this level, which probably we can get a better outcome, because only posterior in osteoporotic bones probably will have a chance of failure or back out of implant. We did this, and nearly again a reasonably good follow-up, 2 years now. She is managing. Next case, back pain. Patient came on stretcher, again was treated for lower back pain and porotic fracture. All these things, when he suddenly worsened, the neurology was referred to us, and this is the picture. L2 lesion looked like straight away a tumor to us. We investigated thoroughly, and it came out to be adenocarcinoma, as the primary was in the lungs. We prefer, as I said, embolization by choice, because we always feel it's very comfortable when there is significant less amount of bleeding in most of these kind of tumors in renal cells. And this is what was our experience, and we did a complete anterior corpectomy and fixation, and the patient is under treatment with the oncologist and is managing. We had a last follow of 9 to 10 months. Now patient is yet to be followed up. 76 man, again back pain, lower limb weakness, hyperreflexia. These are again challenging multi-level issues. Again, we think various things can be possible. Investigations are very, very important and paramount. Discussion with the radiologist, a team approach, and we can get better ideas what it can be and what we should do, where in view of his neurology and worsening of the symptoms, we planned for surgery afterwards, and this patient managed with chemotherapy afterwards, and it's 1.5 year follow-up we had when he followed up with us last. 60 man, again complaints of back pain, and he was with bypass surgery in the past, various comorbidities, and this is again a picture which we were very concerned. We thought of whether it can be infection or tumor. The reporting was infection versus tumor metastasis. All these things we investigated thorough, significant compression, and in view of neurology, we planned for decompression surgery for this. Everything was thoroughly checked as routine, and we did a decompression and fixation in this, which turned out to be a lymphoma. His power was grade 2 to 3 in the lower limbs. The reason for surgery was that, and he significantly improved. We are closely watching. 49-year-old man again comes with back pain. These are very, very interesting cases when they come to us in the clinic, and when we see these kind of severe compressions, and we have to be very thorough when we plan for treating these kind of patients. We have to see the longevity, we have to see the prognostications, comorbid factors, and what best we can give in this situation. I am showing only the complex cases where we have offered this kind of treatment, but a team approach is very, very important in this. And if you see, most of the cases are completely worked up with this kind of cases where we did anterior decompression and fixation. This came out to be a neuroendocrine, very uncommon small cell carcinoma, and the patient was under treatment with the oncologist. And before I sum up my cases, this is one interesting case. A 28-year-old man came to us with severe pain. This is a large disc, was not getting better, and he was referred for further treatment in view of his severe pain and not settling with local treatment for many months. We planned for anterior cervical decompression. He went home very happily, and after 1 year he comes back to us with this, because his pain was, again, there was pain in the neck. And then when we did all the investigations, and this is what we found, and there was no option but to plan for a decompression. We did a posterior surgery and decompression. Intradural schwannoma was the outcome for this interesting tumor intradural. And this patient is now almost 5-year follow-up, completely happy, doing everything, exercise. He is a farmer by profession. And I thank you all for patient hearing. Yes.
Excellent, Shailesh. Just one point before Dr.
Patkar, sir, yeah.
The next, yeah. So in osteoblast, do you do an intraoperative CT scan after you remove the lesion? Because a lot of times you tend to miss it. So confirming the lesion with a CT scan immediately after removing it, and if you see the lesion and need us in the CT scan, it is confirmatory. So it's quite, we had missed one. So after that, we had started doing intraoperative. Immediately, we sent this specimen for a CT scan.
Yeah, what I did, I will tell you of a real life experience. This is again 9 years back when I had a similar case. And if you see, I had done a CT scan marking, and we keep the needle inside that lesion so that we don't miss the level. Most important thing is that if you miss the level, you miss the level. Patient will not get better. And it's a small array. Sometimes we can have some kind of a very small misjudgment can lead to a wrong level. So we had a T2 spinous process osteoid tumor. And again, this patient was in all this, everything was done, not better. It was a very small, if you see costotransverse junction and T2. In this particular case, at that time, when we did the excision, and he was a very demanding person, very demanding patient, software professional. So we did the excision of tumor exact level, and we did a CT of that patient in the same condition, yeah, under anesthesia, and we got it that the tumor was completely taken out. But I think with the O-arm, things will be much better. We can directly, or most important is exact level is most important in this case. I agree with you. Thank you.
So your question was more directed towards residual tumor rather than missing the tumor. Am I correct?
Right, sir.
No, he was saying they have missed the level. Therefore, he was
So
very.
whether sir, whatever we have removed is the correct tissue removed or not, to confirm it, sir.
So your last patient developed a neurofibroma or a schwannoma after the anterior cervical disc surgery. After how many days? Because it was not there. These tumors are there. They don't suddenly come up, you know.
Yeah. So I think what you said is absolutely right. There is a very good article in the literature, only one case, where there is a possible if you do a contrast in the primary MRI, there is a possibility that this tumor probably was there. And as the disc was large, it was not even reported by the radiologist. The two MRIs were there, and there was no tumor seen.
Because neurofibromas do not come suddenly, you know.
Absolutely. And because of his pain, which came back, so probably it was a double crush kind of a thing. There was a large disc for the first instance, which got better. He got better, he went home, and probably that gave the cord to breathe more, and which probably has developed into a tumor.
The question is, we should do contrast MRIs in all discs.
Yes. Yeah, that is what Esther is important, we have realized again.
Yeah, Shailesh,
yes,
I've seen most of the appendicular skeletal osteotomas recently been treated for the last few years by orthopedic oncosurgeons by CT-guided radiofrequency ablation.
Correct.
So it becomes extremely targeted, minimal invasive, under local, and there is no question of missing out the tumor because you're doing CT-guided, right? So you feel this could be a modality for this kind of tumor also, that you just push transradicular and through that you just put in the.
No, I think now we all are talking about this very radio frequency is one of the very good modalities for osteoid tumors. I completely agree. And if you can do a exact targeted delivery, there is a good answer for this. Ultimately it is for pain relief. They are mostly benign tumors. Very less chance of osteoblastomas to metastasize, 1 or 2%. Therefore, we need to just check. But that is an option nowadays.
Correct me if I'm wrong.
Two issues with the CT-guided radiofrequency ablation.
Yes.
One, the tissue should be accessible. The site should be accessible and away from the neural structure.
Correct.
Because in your case, it was in the foramen.
Yes.
So might not be an ideal case for CT-guided radiofrequency.
Access becomes difficult in CT-guided because you can't reach at times at that level. Sometimes it becomes difficult in thoracic. Okay, thank you very much. I would like
excellent cases.
Thank you. I would like our senior most faculty, Patkar sir, to share your screen, sir. I'm just getting off the screen. Yes, sir.
Just a minute. So how do I share the screen?
You just open it on the desktop and there is an icon in the center, which is a green icon. Just touch it. It will ask you to.
So on the Zoom screen, if you bring your cursor down, you see a green icon said sharing screen on the Zoom screen only.
This is the screen. This is Zoom screen. Now share the screen.
Lower down, there is a green icon which says share the screen. Yeah, you can see share screen. Just tap on it lower down. Yeah, we can see that.
We can see your screen now. Just make it
slide show, sir.
But I'm unable to control the slides. Yeah. Okay, fine.
So just do the slide show. Now you can control with the cursor. Yes.
Dr. Adgaonkar, how much time do I have?
Say till you finish.
I thought we are finishing in 10 minutes, no?
Yes, 10 minutes.
10 minutes. Okay, so I'll just run through some cases. See, I'm a neurosurgeon. Most of the time, patients come to me after investigations. They're examined. I always refer it to the neurologist. So they examine the patient. I don't have to do neurological examination. I don't like to do neurological examination. And then when everything is ready, I'm ready for surgery. So this is a patient who was said to me for disproportionate backache, fever, ESR 50, middle-aged farmer, HIV positive. What are the thoughts that can run into your mind after looking at this scan?
Infection.
Infection, number one.
Positive patient, the disc is involved, most probably an infected one.
Spondylolisthesis most likely.
So what he says, may karma never bite you in the ass. I am karma, this guy says. So this is the actual scan. You want to change your diagnosis now?
Arun.
My name is Karma. Karma never bites you, but I am karma.
Yes, Arun.
So I see a lesion with extensive soft tissues, right?
I'll go back. See, the patient has severe pain. For the value of the severe pain, you can see the lesion is in the disc.
Yeah.
There's a little retropulsion. There's some cord signal change.
Yeah.
The ESR is raised.
Appaji, what you will do?
Thank you.
Yeah, I'll first do the biopsy.
Biopsy.
Ajay.
Biopsy. Good option, yeah. Biopsy.
CT-guided biopsy, yes, sir.
CT-guided biopsy.
Yeah, Ajay.
I think need to see more images. The coronal
So the axial, sir, the anterior tissue you want to see again?
Yeah.
The biopsy.
Yeah, biopsy.
Running fever, mild fever, immunocompromised, HIV positive.
CT-guided biopsy, sir.
CT-guided biopsy should be the option.
Okay. So I didn't accept that because I saw 2 lumens over here.
Oh, that's a aneurysm.
It could be a concomitant pathology. That doesn't explain the disc changes.
This is a mycotic aneurysm and there's fungal infection of the intervertebral disc space. This is very common in HIV. You get a fungal infection which causes a mycotic aneurysm, and there is fungal discitis at that place.
Yeah.
And you can see this.
Yes.
So, no
I saw the X-ray with the stent. So I wanted to tell them, but I desisted.
No, that's why I asked for axial scans again. One could see W1, but axial scans.
Thank you for being honest. But this is the giveaway, you know.
Yeah.
Whenever there is something unusual, the vertebra is intact, and there's something outside the vertebra which is looking unusual. Forget the spine and start looking at what is outside the vertebra. So there was a mycotic aneurysm in the aorta. Of course, the patient was first referred for stenting, and then after the stent, they had to wait because the patient is on anticoagulation immediately. I was not allowed to operate for 2 weeks, and I thought that he'll become all right. But he was in deep, too much of pain. So I had to just go and stabilize that. There was nothing much to be done. But this was the histopath where you can see
I thought the infection, there is an infection which is engulfing the aorta. So we had 1 or 2 cases like this where we had aortic injury while doing the surgery.
Wow, okay.
So I thought that, I never thought of aneurysm here.
So putting a needle inside and God forbid if it starts bleeding, that would be curtains on the table. Now this is another patient. You can see that there is an expansile bony lesion on the lateral mass on one side. You can see that you see this expansile bony lesion, and this is the MRI. And there's an atlantoaxial dislocation, and on the 3D scan, you can see that the lateral mass on one side is destroyed. So possibilities were, of course, tumor and infection. I approached this patient through what I've described and anterior approach, and this is the kind of construct that I use. And I used on one side plate screws and with screw, and now I've got a more than 6-year follow-up where it has healed. There was no need to include the occiput. It turned out to be a mixed TB with fungal infection, which is a very, very common thing in young children.
Polymicrobial.
This is another patient where there is a double level tuberculosis, and she was a very bad risk patient. She was, with almost with a breath count of, 6, because the paraparesis was at a very high level, and plus there was no symptoms in the hands. So I staged it, and I decided I will first do the dorsal spine, and then plan the anterior surgery for this. So, but after I did that and started the AKT, they started regressing, and it healed on its own. And you know, in TB spine, many times it happens that, you know, after the cage sinks, the rod, there are reports of cord, these rod slipping. So this is a slight modification that I made in the rod, where the rod is expansile at one end. So even if there's a little countersinking, the rod does not come out. Anyway, this is just a small addition.
Yeah.
And this is another patient who came with this kind of TB, but patients don't read textbooks. I told the patient this is junctional, this is infection, this is most probably TB. I did a needle biopsy. It was pus. I could not grow any mycobacteria. We started on AKT, and they went away, and it healed. So every time.
Most of the time, Cox heals with.
Yes.
No, without
so this looks so bad. This looks so bad, but this is after about 8 months. So patients don't read textbooks, and they can become all right in spite of all our evidence, all our classifications.
This healed without AKT?
With AKT.
Without surgery.
Without surgery. Yeah, okay.
I think a very important aspect in the treatment apart from AKT is a complete bed rest. If the patient is not undergoing any kind of stabilization. Many times, if a lot of vertebra, a lot of destruction takes place, you have to give it good opportunity to heal without any weight being transmitted across that place. So she was in bed for 3 months. After that, she had a Somaip kind of brace. And this is what happens after 6 months. She's all right. Now, this is my latest patient. Look at this guy. Look at this guy. He's a wolf, you know. And he had a disc. And just for fun's sake, I wanted to show this case. It was quite a frightening experience because when he came out of anesthesia, I had to run outside the OT.
It's a GST, German Shepherd.
That's right. This is you see this patient. This is a chordoma, typical chordoma. Of course, it was operated by my technique of going from the front and transferring the weight of the skull onto the anterior cervical spine. This is what I was talking. You go from the front, operate from behind, and transfer the weight of the skull onto the cervical spine. This is flexion extension at 3 years. Implant is holding very well. Of course, this is published as a new technique of craniovertebral fixation.
So there was no support anteriorly from occiput to the mid cervical.
That's right. So just a minute. Yeah. So the technique is very simple. There's nothing difficult in this technique. Unnecessarily, we're frightened. Actually, there is a safe area lateral to the cervical spine. You can see if you go beyond the transverse process, there is no risk of injury to the vertebral arteries. There is a safe area beyond the muscles. You're not going to injure anything over here. So bend the rod twice. Now, how you fix the rod, there are various options. You can bend the rod twice and fix it onto the cervical spine. After I've devised this with Geon to fix it onto the anterior surface of the cervical spine. Once you push them, they come in the paraspinal area behind. There is no need to disturb the posterior tension band. You can just make parallel incisions and expose the occipital bone, deciding on the CT scan where you have got thick bone. And then you can pass a rod which can be connected by a domino connector over here. And then depending by distracting, pulling, you can readjust the position of the spine. So this was another patient of fibrous dysplasia with a pathological fracture dislocation. You see, there was almost no bone in between. She was quadriplegic and bedridden for 3 months with a catheter. She had been biopsied elsewhere. Fibrous dysplasia had been diagnosed. And this is 1.5 weeks after surgery.
Excellent.
Okay, fine, doctors. Thank you very much.
Thank you, sir.
Thank you, sir, for a great presentation and innovative technique. looking forward for such long follow-ups for this kind of challenging cases which you have projected and showed. I must compliment for your innovations for, because they are not textbook things, and each case can be very different, and how to deal with these are the things which are going to come in future, because a lot of different pathologies we are seeing these days with new advent of investigations. I thank you all for a great show today, and showing your very good cases, good discussions, and I would just like to say some concluding remarks that lesions in spine, when we think about anterior and posterior, when we think about anterior, very commonly we think about infection. Infection can be TB or non-TB.
Arun wants to say.
Yes, Arun.
Shailesh, I was just thinking, while we're all here, why don't we start a big, like a WhatsApp group just between ourselves, and if you guys are coming to London or I'm coming there, or if you have interesting cases, we could all discuss. It's just a thought. I'd like to keep in touch with you guys.
Yeah, definitely. Yes, we keep it. Yeah, thank you, Arun. Definitely, we will consider. And just concluding remarks, where you have to think about anterior as well as the posterior things which are there. Anterior infection, very commonly we see TB, non-TB, benign lesions, neurofibromatosis, hemangioma, GCT, eosinophilic granulomas, ABCs. In malignancy, we see metastatic and myelomas. In posterior, we see mainly benign, like osteochondromas, osteoblastomas, and osteomas. Malignant and metastases are definitely there, and also lymphomas. These are the things which can come, and certain very, very rare tumors also we have to keep it in our mind. Most important is clinical examination, thorough clinical examination. We have to do appropriate investigations, and in case of need, we can discuss as a team approach to your colleagues in case you find difficulty, because they are challenging cases. There is nothing wrong in taking opinions from your colleagues and going ahead with these kind of challenging cases. I compliment and thank you all once again, Dr. Arun Ranganathan especially, for giving us the great time for this webinar. Sushil Patkar sir, Rajesh Parasnis, Bibu Mohapatra, Dr. Appaji Krishnan, Dr. Ajay Kothari, Dr. Himanshu Kulkarni, for indeed a great time. We almost completed 3 hours for this interesting lesion in spinal session. And of course, last but not the least, Dr. Ashok Sham for being there as a great support. Pune Orthopedic Society and Pune Association of Spine Surgeons, thank you all of you for being there, and we look forward for such good webinars in future. Thank you all. Thank you very much.
Thank you very much.
Shailesh. Thank you, Shailesh. And I would like to thank you for getting us, all of us, in this platform and share our skills and knowledge and enrich everybody. Thank you so much.
Thank you so much. Thank you, everybody.
Thanks, Shailesh. Yeah.
Thank you so much. Thanks very much.
Shailesh, get us on the WhatsApp group as Arun said.
Yes, we will definitely.
Let's get this thing done.